the official start time. Thank you. So can we please settle down so we can start? Thank you, everyone. Thanks for coming once again. You're welcome. I think I've said this up to 3 times. You're welcome to the Evidence for Change Learnings and Recommendations for Quality Maternal Care. So at this event, we just don't want to talk about the problems. We just don't want to talk about the challenges. We want to talk about the solutions and to celebrate organizations and initiatives that are actually creating and implementing amazing solutions for better quality maternal care in Nigeria for women, children, communities, and society at large. So without saying much, right now I'm going to invite for the welcome remarks, Vivian Ihe, the Managing Director, Nigeria Health Watch.
Good morning, everybody. Good morning. Morning. It's really wonderful to welcome you all this morning. Again, I will apologize for the slightly later start. I know many of you made a lot of effort to be here on time, so thank you for bearing with us. And we're really pleased that we've managed to get you all here today. As Bumi mentioned, my name is Vivian Ihekwazu. I'm the Managing Director of Nigeria Health Watch, a health communications advocacy organization for those of you who are getting to know us for the first time today. So, Evidence for Change. We've been planning this event for quite a while, and we have to thank the MSD collaborators very much for bearing with the date changes and the pause and asking you to be patient until we got confirmation about the dates this event will go ahead and also about the structure. So to our fellow MSD collaborators, just to say thank you very much. We're also especially pleased because we've had our MSD for Mothers partner events, collaborator events in the past. I think the last one we had was, I think if I'm not mistaken, 2019. In Fraser Suites, or was it 2018? No, it was 2019, around October. And there were a few other projects that were there, and there's some new ones that are here with us today. And that really was the first time that we all got together, and I think we got to know each other a bit better at that event. But today is a bit different. Almost 3 years down the line, we meet again. And this time, we're going to spend a lot more time talking about the projects we've been working on, talking about the support we as an organization have provided you with, and also talking about some of the insights and learnings from the different programs that we've been supported with. Before I go any further, I have to, of course, thank MSD for Mothers for supporting us, Nigeria Health Watch, and all other collaborators and all the work we're doing around maternal health care. So thank you very much to MSD for Mothers. Iyaduni Olubode is not able to make it here today, but she is on Zoom, and she'll be sharing a few words. I'd also like to say thank you to some of the stakeholders who we work with, who are here with us in the room today. Some of them are not here yet, but just to go over some of them that we will be seeing today. For example, we have the Kaduna State Ministry of Health, the Private Health Institution Management Agency, PCN, Pharmacist Council of Nigeria, Association of Nigerian Private Medical Practitioners, Association of General Private Nursing Practitioners of Nigeria, Kaduna State Primary Healthcare Development Agency, and the Private Health Institutions Management Agency, and of course, Ministry of Health. So some of them might not be here today just yet, but we hope they will join us shortly. And some of them will be giving some of their goodwill messages. I think it's really great for us to also hear from our stakeholders that we work with, and really, of course, support the work we do as MSD for Mothers collaborators. And of course, not forgetting, let me just also highlight who else is in the room, which MSD for Mothers programs are in the room. We have MDoc, nice to see you. We've got Village Health Workers, Girl Child Concern, of course, Dr. Mandara, who's our avid champion for everything that's to do with maternal health and also girls uplifting. We've got Maternal and Perinatal Database for Quality, Equity and Dignity WHO program. Unfortunately, Dr. Bosade cannot make it here today, so they're due to do a presentation which Ifemwa, Director of Policy and Advocacy, will be doing. And of course, we have LifeBank, who are here today. I think when we first had our convening in 2019, you weren't quite part of the collaborators, but we're really excited to have you here today. I mean, LifeBank, you know, the work Temi and your team do, we all know is amazing. And not just in maternal health, but just around, you know, COVID and all the oxygen tanks you supplied. So really, really happy to have you here today. Smiles for Mothers, ably represented by Uche. Good to see you this morning. And we have Mom Care. They're not quite here yet. I don't think I can see one of the two. Oh, sorry, yes. And Integrity Project. And Saving Mothers, Giving Lives 2.0, Dr. Amina. Nice to see you this morning. And also Paulina, is she here yet? Yes. Hi, Paulina, nice to see you. And then the Right Come 3 Project, we have Dr. Ugo Okoli with us from Japago. Nivi, we have, yes, good to see you here. And Nigeria Health Watch, of course, as we know, the conveners who have brought you all here today. So briefly, why did we think it fit to bring all of us here today with all of our stakeholders? So really, Nigeria Health Watch, over the past 18 months, we've been working on maternal health advocacy and communications, which is where I think we intersect with you quite a lot. Ultimately, really to spotlight the importance of quality care in maternal health in Nigeria through MSD-funded projects. They all support us. So over that period, we've interacted with you in many different ways. There's really great work that goes on. And really, obviously, Yaduni will go into more detail. MSD's goal is really to create a world where no woman dies. And their intervention in Nigeria is through all the work we do, all the projects we do. And really, over the past 18 months, the work we have been doing is supporting your teams in whatever way you need to communicate some of that work you're doing. Because in as much as we do the work on a daily basis, it's very easy to get bogged down into it. And it's important to really spotlight some of these solutions, which we do to support the government, to support Ministry of Health, to support our state ministries of health, to really provide them often the technical expertise and also test cases and examples of interventions that can ladder up to solving this issue of maternal mortality and obviously better quality maternal care for all women in Nigeria. I think maternal health care, whenever we have any event, one thing I always notice, every single person has a personal experience. Every single person is touched by it. So, you know, in a country where one of the leading causes of maternal mortality is postpartum hemorrhage, and there are interventions that can solve that. We don't want as a country to be top of all these rankings where the health indices are not great. And as I said, maternal health and maternal mortality affect every single one of us in this room. Even if not personally, we always know somebody who's been affected by it. And collectively, as a society, we really need to spotlight and highlight some of these solutions so that we look forward and we know that when a woman is pregnant, that there isn't that fear that something may happen to her, that it's supposed to be a thing of joy, you know. Pregnancy is not a disease, should never be seen as such, and should be a thing that's celebrated. So through all the work we do, we are all working together to try and solve that problem. And so the approach we've taken really to spotlight quality of care for maternal health, we focus on really 6 thematic areas, and a lot of your projects kind of fall within those 6 thematic areas. Namely, really understanding the quality of care gaps and how do we address those. Quality assurance is really, really important because in as much as you may access healthcare, quality of care can be a big factor in outcomes. The important role of private sector capacity, the government cannot do it alone. And the government needs private sector intelligence, capacity, expertise to support them ultimately in achieving a lot of their goals and implementing some of those policies. Affordability is quite exciting. You know, we have the Basic Healthcare Provision Fund, and now with the National Health Insurance Authority Act signed, what that ultimately hopes to do is those who are more vulnerable have access to healthcare. And cost of care is a big barrier to accessing healthcare, especially for mothers. When we did our 18-month maternal death review in states in 2018 to 2019, we were looking at the reasons why women were dying in communities. Because as we know, the majority of women give birth in communities, not in health facilities. And one of the things highlighted was cost of care. Apart from, of course, actually accessing a primary healthcare facility, but actually affordability and cost of care was a big factor. So this is also one of our thematic areas. And then digital support and digital technology. I mean, we all know that with the rise and use of new innovations in healthcare, digital technology will really be a game changer, especially in those hard-to-reach areas and hard-to-reach communities. So some of the MSD-funded projects address that. I know one of them is not here, Omomi. They had a program whereby they were helping with quality assurance of health facilities. And there are many other projects like Mom Care being another one, where digital solutions are very important. And then finally, evidence for change, which really I think is the culmination of a lot of this work that we're doing with all of you. How do we use some of this evidence to change some of the narratives and to change some of the indices around maternal deaths in Nigeria? So really, with the objective of evidence for change is to use the outcomes of a lot of the projects that you're working on as models that can be repeated and upscaled as really best practices for improving maternal care in Nigeria. And we want to really highlight some of the quality of care gaps and approaches that many of the projects have used to improve quality of care for maternal health in Nigeria. All of this through, of course, the MSc-funded programs that we're all working on. So today we have a very busy schedule, as you've seen. We may be running a little late, but we really are keen to get through most of it. We've got 3 really great panel sessions where I think another reason why we're so excited about this event is we have all of you in one room. And I'm sure that collectively we're all MSD collaborators, but we don't often know what everybody else is really doing. So throughout the panel sessions, we hope that will be an avenue to really tease out some of those learnings, because they are things that I'm sure that we can learn from each other and also share our challenges. And with our stakeholders here, even better, because they too can give us some of the feedback, and we can also work collaboratively with them to ultimately support them in any way we may not be right now. And at the very end, what do we want to do? We want to be able to synthesize some of the findings, some of the learnings, and some of the insights. How can we use these as models to improve quality of maternal care in Nigeria? So without further ado, I will just say thank you once again on behalf of myself, my team, for coming this morning and spending today with us. I'll hand back over to Bumi to continue. Thank you very much.
Thank you, Vivian. Indeed, the work that we do is all connected as partners, as organizations, as initiatives. So now we'll be welcoming Iyaduni Olubode, the Nigeria Director, MSD for Mothers, who is joining us virtually, and she'll be giving the opening address.
Thank you very much, Bumi. Good morning, ladies and gentlemen. Can you hear me?
Yes, we can, Iyaduni. Please go ahead. Yes, we can. Thank you.
Thank you. Distinguished guests and colleagues, thank you for gracing our event today. I want to especially greet you and welcome you in the name of the organization I represent, MSD for Mothers. It's my pleasure to share with you a few thoughts ahead of this conversation that is to be led by the implementers, the boots in the field, where they'll be sharing their experiences, sharing their findings on the innovative ways they're addressing the maternal health challenge. My name is Iyadunni Olubode, like Bumi introduced, and I represent MST for Mothers in Nigeria. Some of you may be familiar with MST for Mothers, but for those of you who aren't, we're an initiative of MST, also known as Merck in the US and Canada. And we believe in the possibility of a world where no woman has to die giving life. We believe that pregnant women everywhere in Nigeria can have access to respectful, high-quality care that ensures the best maternal outcomes. We believe also that healthcare workers can be equipped with the tools and the resources to deliver this high-quality care. We believe that the voice of the Nigerian woman is pivotal in shaping the solutions targeted at this Nigerian woman. And so our belief is not just, belief by itself. Our belief is supported by investment in and collaboration with implementers who you'll be hearing speak today. And they'll be speaking, there's three things I want to highlight around the conversations we're having today. First is our implementers, they seek to understand our maternal health challenge, and this is an approach that we bring to our work. Understanding the maternal health challenge from the perspective of all stakeholders, especially the women. And one way to better understand why women are dying is to strengthen surveillance mechanisms, what many of us call MPDSR, through maternal and perinatal death reviews at community, primary, and secondary levels. Through engaging women, and technology offers us a multitude of channels to do this, to reach more women across the country faster and in real time, so that we better understand the maternal health challenge. Second is to fashion solutions collaboratively, and the key word here is collaboratively, because once we understand the challenges, we all have a role to play in making sure we arrive at solutions that work. We can address that solution, that challenge better if we go together. Women, their family members and friends, healthcare workers, public sector, private sector, community members, community leaders, religious leaders. Every single one of us have a role to play. And our Strengthening Safer Systems for Childbirth initiative, launched by MST for Mothers last year, is designed to further drive those collaborations, where we're seeking for organizations to work together in clusters. We're joining our funding with other funding organizations to further implement and drive maternal health solutions that are proven to work. Finally, we need to review together what works and what doesn't. This review allows us to refine our common approach. It allows us to take advantage of each other's learnings, and it helps to ensure that we're all pushing in the same direction, because if we are to achieve the Sustainable Development Goal of less than 70 deaths per 100,000, we all need to be working together on it. Today, Nigeria Health will be facilitating panels. I think the first is on empowering and equipping healthcare providers to deliver better quality maternal care. The second will be on expanding access to better quality maternal care. And the third is supporting women through that pregnancy journey with better care. We'll be hearing from colleagues, many of whom are people that we've worked with or that we're currently working with and have been in the thick of the projects, interacting with the women, interacting with the healthcare workers. They have experienced what works and what doesn't. And they're going to be sharing with us the collaborative ways that they've worked, the challenges that they've had, what has worked for them, and what they think still needs to be done to further provide traction for the work that has been done. So I implore you to please listen attentively, please save your questions, and let us have an interesting conversation, and let's leave today with some commitment to implement implement the solutions that work and to change the way that we're all addressing maternal health so that we can arrive at that vision of a Nigeria where no woman has to die giving birth. Thank you very much.
Thank you very much, Iyaduni. Iyaduni has given us more, kind of encouraged us, why we're here, why we need to be here, and to let us know that we're not just here in vain. We're actually here for a purpose, and not just working in silos, working as a collaborative team, because we're all working for the same cause: better quality maternal care for women, better quality of care for women and for their communities, for their families, and for the society at large. Thank you so much, Iyaduni, and we are excited to hear about the innovations, to hear about the learnings, the experiences from the various initiatives, the various organizations, the projects, and we hope that at the end of today, we are able to take back one or two things to, accelerate our collaboration and accelerate the development that we are after. So now we are heading straight into the presentations. And I know everyone has the agenda. Right about now, we'll be having the presentation on empowering women through digital technology, and that will be led by Chigozie Abiakam, who is the Associate Manager, Women's Wellness for MDOC. And MDOC is one of the members of the consortium of the RECOM3 project, and we're really excited to hear about that, to hear about their role in the project and their role as members of this consortium. Chigozie.
Good morning, everyone. It's a pleasure being in the presence of all the amazing stakeholders that help to make a difference in maternal health in Nigeria. I want to use this opportunity to say a big thank you to Nigerian Health Watch for constantly, spreading the word, showing the work that all these stakeholders do to improve maternal care in Nigeria. My name is Chigozie Abiakam. I am a pharmacist by profession, human service professional, and associate manager for women's wellness at MDOC Healthcare. Today, I will be doing a presentation on empowering women through digital health technology and then providing holistic support through virtual coaching and digital nudges. Okay, so we at MDOC, we optimize the end-to-end self-care experience of our members living with, okay, yes, thank you. We at MDOC, we optimize the end-to-end self-care approach of our members living with regular and chronic health needs. We do this by harnessing the quality improvements, methodologies, and behavioral science, data, and technology. This keeps going fast. Okay. We offer a 4-pillar high-tech, high-touch approach to integrated self-care using our platforms, Complete Health, Navi Health, Nudge Hubs, and MQN. So Complete Health is the virtual, it's a virtual coach platform and that offers digital nudges, and the members can also monitor their vitals through this platform. Our Navi Health platform, it's a dual-coded platform for patient navigation and patient reviews. Then we have, okay, thank you. Okay, so we have our in-person nudge hubs and community ambassadors where our members can work in and meet with a health coach and have one-on-one coaching and have their vitals checks. Finally here, we have the MDoc Quality Network, where we have our tele-education sessions for healthcare workers, nursing mothers, and pregnant women. Like I earlier mentioned, NaviHealth provides easy, accessible, convenient patient navigation. We also provide a review system. And I want to say that the review system is actually a very, very powerful tool in providing visibility and confidence for the facilities. So the patients, give their reviews across 6 dimensions of care: quality, equity, effectiveness, efficiency, safety, and women-centeredness. MDoc provides support across women's life course. For instance, we give support to our members living with breast cancer. And we also provide a financing mechanism for them where they can, which helps them afford, their medication. We do this in partnership with Roche, Rupee Flexi Health, and Sterling Bank. Through the RICOM3 project, funded by MSD for Mothers, led by Dr. Chibugo of Japaigo, and in partnership with MDoc and HSDF, we have been able to provide virtual support to our women, to WRAs, to our women of reproductive age. We provide, we apply the quality of care model and help improve the prevention, early detection and management of chronic risk factors in maternal health. Our clinical areas are preeclampsia, eclampsia, obesity, anemia, and the rest of them. We are across Lagos and Abuja. Our women-centered approach to quality model helped to reduce the risk factors of indirect causes of maternal morbidity and mortality. We do this through on-site skill training, in-person, virtual tele-education sessions where we help to enhance the knowledge of our healthcare providers. We also identify the quality gaps, set improvement measures, and develop quality of care measures. We also provide virtual care services to our women of reproductive age through our tele-education sessions for pregnant and nursing mothers. Finally, we create a platform where we encourage peer-to-peer learnings, where some select facilities and our digital coaches can come together and discuss successes and learnings. Through the RICOM3 project, we conducted a digital prevalence study. And in this study, we asked our members if they knew that they had elevated blood pressure. We did this across some local governments, and some of them, in AMAC, 4% gave self-reported raised blood pressure. 9% had raised blood pressure according to the Nigerian classification, and 33% had raised blood pressure according to the AHA classification. On the right here, you can see that we've tried to find out, the level of knowledge that they had about this condition. And only 58% only 58% had taken their drugs in 2 weeks. Only 2% knew to reduce the salt intake in their food. We have recorded some impact in our key indicators. Our coach-led platform has shown improvement in self-efficacy from 41% to 84%, improvement in digital literacy from 49% to 82%. I just want to mention here that we are the first super hub for ECHO in Africa, and we have recorded 14.4% increase in knowledge of healthcare workers, and then 12% increase in knowledge of our members. So this slide just shows some more impact. You can see here that 88% of women are now comfortable using their phones compared to baseline. So there was an increase of 36% from baseline. And then we see that 95% knew the benefits of exercising during pregnancy, a 37% increase from baseline. This is our outcomes from blood pressure. We show very promising results. About 54% show improvements and 63% show control in BP. We understand our members and we use, we meet them where they are. We use our women-centered approach to continue to provide digital nudges and virtual coaching for our members. Thank you.
My mother, you must see my mother, come and see my mother, hey. My mother, you must see my mother, come and carry on your max, come and carry, if you want, come and carry, if you want, come and carry on your max, come and carry, if you want, come and carry.
I'm usually not the type that will say, okay, let me check my BP, or you just move until maybe when you break down and now go to the hospital. But now I'm intentional about it, and from time to time I go to check my BP just because I know that Coach Chuku will call me to say, okay, what are the numbers? Is it good? Is it low? Is it high? Talk about my what I eat and exercise and all. You're really doing a fantastic job there at MDoc.
Thank you very much, Chiagozie, for that, and thanks for the interesting video. So, without saying much, we'll just move to the next presentation, which is an experience sharing session, just for about 5 to 10 minutes. And this will be handled by Ms. Zara Zarma. So Ms. Zara Zarma is one of the most outstanding village health workers from the Girl Child Consent Project. So she worked with a team to provide health education and other health support facilities for women in villages in Borno State. So she'll be coming in now to share her experience, and she's here with the support or assistance of Dr. Mero Mandara, the founder and board chair of the Girl Child Consent. So we are very happy to have you, Zara, and you can now come for your presentation. Thank you.
Good morning, everyone. My name is Zara M. Zelma from Borno State, Maiduguri, Kwandiga local government area, Wat Jalori, settlement Gomari Kerekri. Okay. Hello. Ini magana wa? Ko ni sallama ne? alaikum jama'a. Sunana Zara Zarma from Borno State, Maiduguri, Kwandiga local government area, ward ina Dalori, settlement ina Gomari Karekiri. A gaskiya dai yadda na samu experience a GCC na ji daɗinsa sosai, bari in ba ku labari kaɗan daga cikinsu. Da farko dai ni 'yar kauye ne kuma 'yar gudun hijira, muka zo Gomari Karekiri. A hakan sai ana neman ma'aikata, kuma ni kaɗai ne a cikin community mu wanda na iya karatu da rubutu. Shi ne muka je muka samu su wannan suka yi mana malaminmu, Malam Abdullahi, aka kai mu aka yi mana interview, aka ɗauke mu aiki, muka je training, suka yi mana 3 weeks training. Gaskiya na samu okay.
Hello, my name is Abdullahi Mohammed Mainat II, the Monitoring and Evaluation Officer of the Girl Child Concerns. I'm here to translate in English language just a few words of experienced village health worker. As she said, her name is Zara Zarma. She's an IDP, a victim of the insurgency. They left their local government and resided in Maiduguri. But during the 2015 government, that the federal government have recovered some of the local governments, the MSD for mothers marketed 3 local governments, which is Kwandiga, Bama, and Goza. That is the most heated. There are no doctors going to the community there because they are all afraid of their life. So the initiative of the GCC is to now create village health workers within the community so that they can now at least assist their people in referral cases to the facility, because most of our people, especially those in the downwards community, they don't like going to the clinics. So we selected 90 from Goza, 90 from Bama, and 60 from Kundiga, and Zara being one among them. While we are here with Zara, all these village health workers that have been working with our organization, they are all volunteers. All volunteers. But because of her dedication, all those years, she has been active, because I usually go for monthly, quarterly supportive supervision, and that's why I recommended her for the purpose of this visit. Now she wants to just share her experience, little experience about the work she do as a village health worker in her community. Thank you. Continue.
To, gaskiya ni na sami experience dewa da abubuwa dewa ba mu sani a kauyen mu ba. Amma a dawan GCC mun samu karuwa dewa. Da suka yi mana training na 3 weeks akan cewa an yi mana akan mata in ta samu ciki me za a yi mata, a kai ta asibiti a yi mata awon ciki. Mutanen kauyen mu da ba su san haka ba, suna tsoron mutanen asibiti, amma yanzu sun gane, kuma mun je mun fahimtar da su. In sun samu ciki su je asibiti, bayan sun aifu su je postnatal, a yi ma jinjirin allura na immunization su ɗoka. Muna zuwa muna samun bulamominmu, community leaders namu gabaki ɗaya mun sanar musu akan cewa gashi mun zo mu taimake garinmu ne. A hakan muna zuwa gida-gida mu wayar mata akan cewa in mun samu ciki mu je asibiti a yi mana awon ciki, kuma mu ci abinci masu kyau wanda zai gina mana jiki. Ba wai lalle sai mun cire kuɗi mun je mun siya abu masu daɗaɗe a waje ba. Mu ma muna da shi a gidajenmu, muna noma muna samu, muna wayar musu da kai a haka. Kuma in sun haifu su kai jarirai a yi musu immunization. Da a kauyenmu in mata ta haifu ba za a ba da farkon nonon uwa cholesterol ba, zubar a masa a zubar da nono, sai nonon akuya ake bayarwa. Amma daga nan muka wayar musu da kai, mata tana haifuwa za ta sa yaro a nono, farkon nonon uwa cholesterol. Mun samu karuwa. Daga nan ba mu san in an haifi jariri za a ba shi nono zalla har to 6 months ba. Yanzu a kauyenmu ana ba ma jarirai nonon uwa zalla har wata 6, kuma yaron da aka ba shi daban da wa'insu ma. Mun samu karuwa da yawa, kuma mace in ta haifu da farko in aka sa yaron a nono, irin jini tana zubarwa ma zai yanke. Ba mu sani ba, da mutanenmu da yawa sun rasu.
Thank you. As she said, her first experience as a village health worker, she was taught during the training session, because the training session took place at College of Health Technology, which is one of our collaborators. We usually collaborate with their teachers, with the administration. The facilitators are coming from that college. They were taught. Formerly, they didn't know about antenatal and postnatal. In their own villages, when a woman is pregnant, there are a lot of herbs to be given to her, traditionally. But with the experience she had through the training of the village health workers, she understood that a woman supposed to go to the hospital immediately she experienced that she's pregnant. And after birth, the first cholesterol, usually we have not taken it, unfortunately. We know, because our mothers didn't know that time. But now, they told their people that this cholesterol is very, very important to the child. And because these are their own children, their own daughters, they believe in them. That is the secret the GCC had. We have to go down, because we have to go down to the community. Their own children, those that they can now talk to them in their own, in their language, and they knew her parents, they knew her grandparents. So she has the right and the privilege to go to each and every house to communicate these lectures. And she did that, and actually things now are more better, at least, than before. That is in the aspect of internal maternal, what do you call it? Thank you.
Mun godewa Hajiya Dr. Mairo, ita ne ta wayar mana da kai, a da ba mu sani ba. Daga zuwan GCC mun gode sosai. Yanzu mutanen wajenmu duk suna alfahari da ni ma ina so in zama kamar ita. In na samu dama kafin na siya zan gyara takarduna, in koma makaranta, in zama kamar ita. Kuma ko a mafarki, wallahi ban taɓa ganin Abuja ba, ko zan shiga cikin jirgi in dawo nan ba. Gashi na zo na ga manya-manyan mutane. Na gode muku, Allah ya saka da alheri. Na ji daɗi sosai. Wallahi ban taɓa ganin Abuja ba, ko a mafarki ban gani ba sai yau. Na gode, Allah ya saka da alheri. Na gode musu sosai.
Thank you very much. That was a very harrowing experience. Thank you to Abdullahi for the translation, and thank you to Zara for coming and sharing your experience, and to Dr. Meru Mandara for facilitating this. Yeah, so I wouldn't really go into that because I also got emotional during her speech. And just so that we can continue, I would just invite the next presentation, which is supposed to be, or which is Dr. Bosede Ezekwe, Technical Officer, Reproductive Health at the World Health Organization, Nigeria Country Office. So she's going to be talking about how the World Health Organization is building the capacity of health facilities through the Mp4 Community program. So on behalf of the World Health Organization, Ifi Babatunde Yusuf, our able moderator, has been given the mandate to present, to make the presentation. Ifi.
Thanks, Bumi. Standing on all existing protocols, and I will try to the best of my ability to do justice to the presentation. Zara has just put me in an emotional mood. So today I'm going to be speaking to Maternal and Perinatal Database for Quality, Equity, and Dignity program implemented by the World Health Organization and funded by MSD for Mothers. With the high burden of maternal death and the need to reduce these deaths, WHO has a strategy that is focused on quality of care framework for maternal and newborn health. And the focus of this project is actually to address components on maternal death accountability. Why these deaths at facilities? What can be done? Are they traced? Are they avoidable? Are they preventable? And that was one of the reasons why the project was birthed. The need for the Nigerian government to actually account for deaths that happen at health facilities and to see how these deaths can be prevented. And with that, they set out to build capacity of health workers in the country, and also to identify medical officers who will actually take this data. And across board, they've had a total of over 50 hospitals in the private and in the public sector at the PHC level. And with the implementation of this project, they had innovative approach to implement these that sort of aligns to existing structure to ensure that all data collected for death actually feed into the national DHIS data. The Mp4 Community Project is one of the innovative strategies that they have. They also have other ones, but I'll be focusing on the one that speaks to why we are here, which is the Mp4 Community Project. And with the project, it's focused to address two key persons who are the babies, the first few 7 days of their life, and the mothers within 42 days of either having a child or terminating ectopic or difficult pregnancy, and also after they give birth, if there is at any point in time a mother dies. And this process starts from once they come into the health facility. So the moment a woman is pregnant, the moment she registers for antenatal, there's usually a data collection which is fed into the system of the health facility. And while the mother is alive and while the baby is alive, there is a cycle that they go through to ensure that basic history is taken, and track record of history of their health is also taken as well. So at a point where a mother dies, there's a cycle that comes into play. The medical officer documents that. And then there's an assessment as to why the cause. Is it as a result of preeclampsia? Is it as a result of sepsis, infection, or as a result of bleeding? So through that, there's an audit process that is established to sort of find out the root cause of the death. And this data is also fed into at the national level. So it's not just about collection of data in Nigeria, but also using this data to make informed decisions that improves the health outcomes of mothers while they give birth. And with this, they've been partnering with Federal Ministry of Health across the Reproductive Health Department to ensure that beyond the project, this is integrated into the system. Beyond the lifespan of the MSD-funded projects, alongside with other partners, there is a need for the government to actually integrate this data into the national data, especially the NDHS, to ensure that there's a continuum within the maternal care spectrum. And lastly, to also look at the program, they've sort of articulated different levels of data from the local government to the state and to the national. And this ensures that the data is coming from somewhere, it passes through government stakeholders, and it goes straight to the Federal Ministry of Health. And with this implementation, it hasn't been without its challenges. And a few of the challenges that has actually been impacted in the project implementation has always been health worker retention, in the sense that there has to be consistent training of when staff are either resign or relocate or are not satisfied with the working climate, they sort of resign. So with that, it's affected the implementation of the project, and they have to retrain new and higher staff. And there's been the issue of governance, with transitioning to Federal Ministry of Health, which is underway, and that has been addressed in the sense that there's been a stronger or strengthened collaboration with the Federal Ministry of Health, who are now championing the Mp4 Community Project. And also in terms of costs, there's been some minimal challenges with operation costs, running the costs in terms of internet, in terms of laptop provision, and all of that. But regardless, we've had cases where hospital management have taken it upon them to make provision to ensure that this data is collected as and when due and fed into the national DHIS data. Additionally, there's been institutional challenges with the COVID and with the lockdown and with the constant strike. But with that, the team has constantly pushed to ensure that number of deaths are accounted for, the causes are identified and addressed across the health facilities they work in. And with that, they've been able to enroll and identify about 86,000 pregnant women and new births have actually been identified, enrolled, and there's been a death audit of about 95% rate. That means that hospitals are beginning to, internalize, accept the need to account for these deaths. And beyond the health facility accounting for maternal death, there's also been the willingness of community as well to be a part of the process, to understand the reasons for these deaths and how they can actually be avoided and addressed. And with that, in the first year, they recorded about 69,000 live births, 4,998 stillbirths, and 1,090 early neonatal deaths. And it's interesting to see that this data is actually feeding into the national. And that gives us hope that within the next couple of years with the census, there's going to be the need to actually make evidence-based decisions on matters that affect maternal health and to improve the health outcome of mothers. And beyond numbers, the database brings to light quality of care for women and babies at a national scale, which is the aim of the work that we all do, all of us present here. Thank you all for listening, and I would like to hand over to the MC. Thanks.
Thank you, Ife Babatunde, for that presentation, and you did justice I'm sure Dr. Ezekiel will be proud. So just going into the goodwill messages, I know we are a little behind schedule, so we have to really rush through that. So for the goodwill messages, we'll just have a few of the stakeholders, a few of the participating partners, stakeholders speak to their role in the work that their partners did, and just give an encouraging statement. So first of all, I'm going to welcome Dr. Neyu Iliasu, the Director of Primary Healthcare, Kaduna State Primary Healthcare Development Agency, if he's around for his goodwill messages. And we'll be giving him 2 minutes. Thank you, sir.
Good morning, everyone. My name is Dr. Neyu Iliasu. I'm the Director of Family and Community Health Services with the Primary Health Care Board, Kaduna State. Good morning. I hope it's still morning. Yeah, it's still morning. All right. So I first of all want to thank the Nigerian Health Watch for bringing this kind of a meeting that has major stakeholders in terms of maternal, newborn, and child health, mortality, as well as morbidity in Nigeria. For us in Kaduna State, we've been having different support from different stakeholders in terms of these indices of maternal, newborn, and child health. And unfortunately, the indices has not been too good for Kaduna State, but we have been well supported. And from the recent surveys that are ongoing, I've been told from the grapevine that Kaduna State is far ahead of where it was before. So thanks to all the support that we've been getting in Kaduna State. We have been working with Pathfinder, and as well as in several fronts to help in raising these indices, and they have been supporting us in training, capacity building, especially in BMONC, also PPFP, postpartum family planning, as well as training of, especially in the aspect of the private sector, quality of care, and they have also been part of the Kaduna State team for quality of care, and their TA has been very, very helpful and helpful, and they have been supporting us in not just the private sector, even in the government sector. So thanks to them. And to the rest of us that are here, I'm sure that you will be well pleased to know that I have never been in this meeting, and this is my first time, and I'm pleased to be here to learn and get how we can learn and have evidence to work on what we have, improve what we have as evidence, and improve our service delivery. Thank you very much, everyone.
Thank you very much, Dr. Iliasu. We are grateful for the work that you do in Kaduna State, and I'm sure many of our partners can attest, not just Pathfinder, Society for Family Health, and the other partners that work in Kaduna State. So next we'll have Dr. Kayode Adeshala, the president of the Association of Nigerian Private Medical Practitioners. Dr. Adeshala, thank you.
Good morning, everyone. I want to start by congratulating the Nigerian Health Watch for the good work that they are doing. It's really a pleasure being here again. Was here quite recently in another meeting of this nature, and I can see that yes, Nigerian Health Watch is really adding their voices and efforts and everything towards the betterment of the quality of health delivery, especially to the Nigerian mothers. This aspect they are concentrating on the long run will help to, better the dirty and bad indices we have as per the maternal mortality rates from this country. Yes, I represent the Nigerian private medical practitioners, and fortunately, this is the particular arm of the NMA that has the biggest widespread geographical spread in the country. There's hardly any part of this country, either the cities or towns or villages or even the hamlets, where we don't have our representation as in private practitioners. And most of us are therefore directly exposed to mothers, and we see and we face the challenges every day. And that also prompted us to, last year when we had our 100th year of existence celebration, one of those things we decided to adopt as a project is the Save a Million Mothers Life initiative, which is ongoing. And early this year, we have also approached the National Health Insurance Scheme, which is now an authority, with a proposal, and that's been deeply looked into now. What we're also proposing with them is that of the pregnant mothers' health insurance, a special scheme that will bring things closer to the mothers. Because on a daily basis, we see women dying unnecessarily, preventable deaths. And so we are, as an organization, as an association, we are really very much ready to partner to a large extent, with the Nigerian Health Watch. Our members, like I said, because of our spread across the country, we at any point in time be able to, spread any good gospel that will bring down these bad indices. There are so many other ways, other factors that we have identified, but we believe that having been here today and witnessing this, we are sure that at any point in time we'll be able to collaborate very well and promote these particular goals being promoted by the Nigerian Health Watch. There are many other areas through which we can promote this. I just mentioned about two of those ones we are working on. But at the same time, I believe last time we had a gathering like this, there was a big, we could feel the presence of the government up to the federal ministry. I don't know if we have that today, because many of these things we are doing, unless we keep drumming this thing, repeatedly to the heads of our leaders, they hardly, go as far as implementing it. Like when the new NHIA thing came up, I was at the NMA gathering in Port Harcourt, our annual gathering, and when everybody was jubilating, some news people came to interview me, and I told them, yes, it's good to jubilate. We now want everybody to have, health insurance, and then we remove the out-of-pocket barrier to, health, accessibility. But at the same time, implementation has always been the bane of every policy in this country. And until that one is really taken on, we are going nowhere. It's one thing to sit down somewhere, they dream good ideas, and everybody's clapping for you. But when it ends up just at that level, it has no meaning at all. So I'm already talking about that. And before I go back to Lagos, I'm sure with my team, we are visiting the Director General. He was CS of the Nigerian Health Insurance Authority. We're visiting him and letting him know that, yes, we are ready, and we're going to be pushing until we see that most of these things that are being promoted, that are being proposed, are going to go as far as being implemented. At that point, we then know that we have actually achieved a very good, progress in the health sector. Thank you very much.
Thank you, Dr. Kayode Adeshala. So next we'll be having Dr. Usman Tijani, the Executive Secretary, Private Health Insurance Management Agency. Welcome, sir.
All protocols are duly observed. I would like to show my appreciation to Nigeria Health Watch and other partners, SFH, Lafia, Bill and Melinda Gates Foundation, and others for organizing this important meeting. I'm really very happy to be here because of maternal and child care cannot be overemphasized in this country. And everybody can bear with me. Any civilization or any country, whatever you have, your sophistication and your seriousness is being assessed by how good you take care of women and children. It's very important. And I come from Kano. My agency is Private Health Institutions Management Agency. We regulate, supervise, and register all private health facilities in the state. Private hospitals, clinics, private laboratories, diagnostic centers, even traditional herbalists. So we see a lot, and I'm sure all of you know how populated Kano is. So issue of maternal mortality cannot be overemphasized. We are here to talk about solutions. We all know the problems. So my own contribution will be, let's emphasize and intensify on girl-child education. It's very important. Girl-child education is very important because it's education that gives us the ability to think. Once a human being cannot think, there's a problem. So let's intensify on that. Let's also intensify on family planning because the population is too much. And no matter how good your services are, the population will always compromise your services. If you have a hospital or a primary healthcare outlet that can take care of 1,000 patients, you see your human resources must move pari passu with the population. So now if that 1,000 increase to 1,500, it will affect your services. So we have to intensify on that. How? Intensify on family planning, girl-child education. Then on the part of government, we need to improve our funding on healthcare. Human resources, equipments, infrastructure is very important because government has to come in. And another important aspect also is the private sector. I deal with the private sector. You see, our population is so much that it's the private sector that has unlimited capacity. Government, you reach a time where the government will have no resources to take the burden of the people of the country, like what is happening now. The largest employer is government. So we must have a way of reaching to the government to improve the private sector. All civilizations and countries that we are trying to copy, if you notice, most of their services are driven by private sector, not government. So I think we have to reach the government and discuss with them regarding this issue. I'm happy that a lot of the states have started the state health insurance scheme, like my colleague is saying. Like in Kano, we have recruited more than 1 million people. But you see, you realize that the burden is too much on the government. People move around, especially with this insecurity. People from Zamfara, Kaduna, Bauchi, Kebbi, they keep moving around because of insecurity. So no matter what you have, the population would dilute your quality of services. So I think we need to improve on the private sector. And also, before I go, the importance of healthcare, I said, cannot be overemphasized. Why? You see, as a clinician, we have a saying. There are primary services and there are secondary services. So unless a country takes care of its primary services, that's how the secondary ones will build up. So we used to give an example with our organs. You see, you have primary organs and you have secondary organs. What are your primary organs? Your heart, your liver, and your kidney. So once they are damaged, no doubt you will die. One will affect the other. Any clinician knows that. If you have kidney problem, it's a matter of time. It will lead to heart problem. It will lead to liver problem, or the other way around. But you see, you can live without a limb. You can live without one eye. Even if you are deaf, you can still have your quality of life is manageable. But if your primary organs are damaged, it's just a matter of time. So I believe we keep putting resources in managing secondary services, not looking at the primary services. Primary services are what? Health, education, food, security. Unless we channel our resources to improve our primary services in this country, we'll just keep going around the same cycle. You realize that they will say Nigeria in 20 years have gotten IGR of $500 billion, but nothing to show. So I think this is how we look at it from the clinical point of view. We have to invest in our primary services, health, education, because they go hand in hand together. Well, there's no time to talk. So I think we just discuss on the solutions and how to improve what we can do. So I would like to thank the organizers and our partners and other distinguished personnel that are here, and I hope we will have a very fruitful discussion up to the end. Thank you.
Thank you very much. So we have Pharmacist Emily Olalere, the Director of Programs Coordinating the Department, Pharmacist Council of Nigeria.
Good morning, everyone. I am Pharmacist Mrs. Emily Olalere from the Pharmacist Council of Nigeria. We are delighted to be invited by Health Watch Nigeria to this program. I want to appreciate Nigeria Health Watch in particular, because they have always ensured that we are invited to provide our evidences. We have quite a lot of evidences. The Pharmacist Council of Nigeria is a parastatal of the federal government of Nigeria that is established by Act Cap 17, Law of the Federation of Nigeria, 2004. And in view of that, the Pharmacist Council of Nigeria has the responsibility, among others, of training, education, training, and practice of pharmacy in all aspects and ramification. And we also regulate the patent medicine vendors and the pharmacy technicians. The Pharmacist Council of Nigeria regulates the pharmacy, the patent medicine vendors, and the pharmacies that practice in the community. And the patent medicine vendors happen, and the community pharmacists happen to be the first point of care for people living in the community. And so, in view of that knowledge by the Pharmacist Council of Nigeria, the Pharmacist Council of Nigeria stratified the patent medicine vendors into 3 tiers. I'm sure some of the partners that have been working with us are very aware of the 3-tier accreditation system for the patent medicine vendors, where the Pharmacist Council of Nigeria had to certify the patent medicine vendors into 3 groups based on their educational qualification. The tier 1, we have those who have school certificate. Tier 2, we have those who have health training. Tier 3, we have those who have the pharmacy technician training, and also within the purview of the Pharmacist Council of Nigeria. So we have to stratify that. And what is very interesting is that the patent medicine vendors are in the rural and hard-to-reach communities in Nigeria. We can remember the evidences provided by Zara just now, who is a village health worker. She said that many people in the community don't like to go to the healthcare facility. So the first point of care is this patent medicine vendors. There's no place in Nigeria that you don't have the patent medicine vendors. So many of these women we are talking about to prevent maternal mortality and all that. These women, the first place they go is this patent medicine shop to seek advice, help, and all others. So, in this stratification, we had a consortium of partners, Integrate E, led by Society for Family Health, they approached the PCN to use the structure. And what is their area of specialization? It is family planning. So they have been piloting with this three-tier accreditation system that the PCN has in place for the past 5 years, I think since 2017. And we actually have a lot of evidences, because in this pilot, Integrate E started with Kaduna and Lagos. And in view of that, about as at January 2022, we had trained over 400 community pharmacists. And then we have also trained patent medicine vendors over 1,000. And currently, we don't have the data. It will be updated by the middle of this year. We will have more information. So these people that have been trained are really doing exploit, in the sense that evidences we are getting is that abortion rate has reduced. There is adequate child spacing, and even maternal, and in view of that, maternal death has also reduced. And from evidences coming, Integrate E have also extended to about 10 more states. And other partners have also approached us in view of, these evidences we are getting, to also use the structure to pilot in some other states. We have IHP and DKT wanting to use these evidences. So I want to use this forum to also, where PCN is welcome, it will want to welcome other partners who want to use this structure to reach the underserved areas and the rural areas. This is one of the key strategy to help to improve maternal care. Thank you very much.
Thank you very much, Pharmacist Emily Olalere. We've had you as a friend of the organization for a while, and thank you for all the work that you do at the Pharmacist Council of Nigeria. So thank you to all those who gave their good messages. We've heard your messages, they're all recorded, and hopefully we can all take that along with us. And as we finally move to the core of the program of today, our panel discussions. So we are going to be, I know Iyaduni Olubode already kind of gave us an insight into what we are going to be discussing today. So the first panel discussion is going to be on empowering and equipping health providers to deliver better quality maternal care. And these participating organizations, projects, and individuals are working really hard through their various organizations, their various projects, to actually provide, improve the capacity of health facilities, healthcare workers, health providers at different stages. So at this point, I'm going to invite the moderator, Mrs. Ife Babatunde Yusuf, who is the Director of Policy and Advocacy at Nigeria Health Watch. Thank you. Okay, so our first speaker or panelist is Dr. Bolanle Fajemirokun, the Director of Partnerships at Lifebank. We are very happy to have you. And then we have Dr. Uchenna Igbokwe, the Principal at Solina Group and Solina Health, and the Solina Center for Development and Research. I hope I got that. You're welcome. So they are the lead organization for the Smiles for Mothers project, and they are doing excellent work. Thanks for gracing our event. And then last but not the least, we have Dr. Ademola Serrano, all the way from Farm Access. He is the Innovation Manager at Farm Access, the lead organization that is working on the Mom Care project, and we are glad to have you. Thank you very much. So I guess, okay, yeah, we have the mics on seat. Thank you. So Ify, take the lead.
Hello. Hi. Thank you very much. Can anyone hear me? I feel like I'm just so. Thanks a lot for the introduction, and hello, better. Thanks. So thanks, Elaine. Thanks again, everyone, and still sitting on existing protocols. So our discussion is going to be essentially revolving around why the need for the project. What was it that we identified? What was the challenge? What was the gap? What was it that needed to be addressed to improve maternal health outcomes? And then what were your solutions? While implementing, what was it that you identified, as the challenge, the core challenge or the obstacles that you needed to address, and how were you able to address that? And what key recommendations would you have, for possible adoption or scale up? Essentially, so that's what our discussions is revolving around. So I want you all to relax and let's have a jolly good time with our discussion this morning. All right, with the work that you do, LifeBank, and we've seen a lot of the life-changing solutions that LifeBank has been doing in Nigeria. And it will be interesting for you to take us back, to tell us how, what was it, what was the drive, what was the reason behind that, what was the challenge that, LifeBank identified, and what was the solution, essentially.
Can you hear me? Good morning, everyone. Can you all hear me? Good morning, everyone. My name is Dr. Bolanle Fajemroko, and I am the Director of Partnerships for LifeBank. I'm just going to go through a brief introduction of what we do. We're building the medical platform for hospitals. We power hospitals and care centers to give quality health care. How do we do this? We do supply chain in the best quality, ensure that the supplies that we deliver to these care centers get to them in the best quality and at the right time. What was the drive for this? My CEO and founder, Temi, was going to have a baby, and she had challenges, and she had postpartum hemorrhage. Luckily, she was in a good healthcare facility where she was saved and her life was saved. And then that was the drive to come back to Nigeria and give back to the society. So what are the challenges that we've found, and how are we addressing them? The very first challenge that we see is there's unsafe blood. What do I mean by unsafe blood? You know that when women are having babies, there's a likelihood that you might need blood or transfusion. So hospitals usually prep for this. We work with over 100 accredited blood banks to deliver blood. How do we ensure that this blood is safe? So first of all, we make sure that you work with the accredited blood banks. We make sure that the blood is transported in cold chain technology. What do I mean by cold chain technology? We use a WHO certified blood box and a strip to ensure that the temperature of the blood is monitored as it's being transported from the blood bank to the care center where it's being used. Also, we realized that somehow the quality of the blood was a bit questionable sometimes, or we had feedback saying your blood had to be returned, or the hospitals complained. So we've come up with an innovation which is in the clinical phase in Nigeria and is being used presently in Kenya right now, it's called the Smart Bag. And the Smart Bag is a blockchain powered technology that tracks blood and its products from the inception where blood is given up until where it's delivered. So there's vein-to-vein transparency, and this gives integrity to the blood and blood products that is being used and accountability. Another challenge that we found was that there was a lack of critical supplies at the very last mile. So in places like Borno, Yobe, the very, very last mile, they didn't have access to critical supplies. And with the help of MSD, we were able to scale. So when we started, we were on we're operational in 3 cities. Now we're operational in about 8 cities, and we sometimes work either with the hospital, so we do a B2B, or we do a B2G. So in Borno and Yobe State, we do a B2G and work with the government so that we're aligned with their policies and we're working towards the same mission. Another operational gap that we found was lack of structural infrastructure to deliver these critical supplies. So how do we address that? We use a multimodal mode of distribution. What do I mean by this? We use drones where applicable. Of course, we need to be cost effective, so we only use drones when the patient has 45 minutes to leave. If the patient has time, then we can use other modes of distribution. We have bikes, we have trucks, we have tricycles, we have boats. So we get to the very, very, very last mile. There was also another innovation that we came up with, which was is called the One Donor app, where we encourage people to voluntarily donate their blood. This kind of maintains the blood pool and encourages people to, help, because there's actually a material shortage of blood. So the problem is not just that the blood may be tainted, there's also a lack of blood. So we incentivize these guys by giving them gifts, and we give them 1 month health insurance just to come and just keep the blood pool full.
Beautiful. Thank you so much. Thank you so much. Thank you so much, Dr. Bolanle. And it's interesting to see that a holistic approach is being taken into the Life Bank initiative, in the sense that from a personal experience, it went through to individual and largely to the society. And that would take us to Dr. Uche's innovation. So seeing that Life Bank is looking at the blood provision, I would like to hear from you what Smiles for Mothers is actually doing in terms of, we know a little bit of provision of medicines and all of that, but we want to hear what was the challenge that was identified and what's the solution that the project is using to address the challenge.
Yeah, thank you, Ify. And I think this builds very well on what Life Bank is doing, because I think it comes from the understanding that 1 in every 5 women in Nigeria that die giving birth die from postpartum hemorrhage, also known as excessive bleeding after giving birth. So with that in mind, I think it's clear that if you're able to change that dynamic, you're going to have an impact on maternal deaths in Nigeria, but also globally, because Nigeria contributes 20% of the maternal deaths globally. So the Smiles for Mothers Consortium, with funding from MSD, and the Smiles for Mothers Consortium is made up of Solina, which is the lead organization, but we're also working with CHAI and CC Hub, looked at how to use human-centered design. By that I mean working directly with communities, with the health workers, with the policymakers, to design innovations to address postpartum hemorrhage, using Lagos, Kano, and Niger states as test cases. Of course, with support from the Federal Ministry of Health. And I think one of the clear problems we found, I think the evidence is right in the files that we're holding, is one of the very big surveys that was done in Nigeria by Dr. Chioma Ejekametal, and I think she has partnered with Nigeria Health Watch as well to publicize it, that finds that in many cases, the reason why women keep bleeding, even when they are in front of our facilities, they are with our doctors, they are with our midwives, is that we cannot quality assure the uterotonics or drugs that we give them to prevent the bleeding. So it's clear from those studies in public health facilities, over 64% of them don't store oxytocin in the fridge, they put it on the shelf. It's as high as 53% in the private sector. Many of the health workers know that when they give it, it doesn't work. So sometimes they add an additional drug or they repeat it many times. We thought that this can definitely change. This is not the way it is everywhere else. So for Smiles for Mothers, one of those first innovations, which is really what I'll be talking about, was looking at the recent WHO recommendations on the use of uterotonics to prevent postpartum hemorrhage, which also recommended a new tool, a new drug, heat-stable carbetocin, that has similar efficacy with oxytocin, a similar side effect profile, but does not need to be stored in a refrigerator. And we know that in many of the settings that we have in Nigeria, where we can't guarantee cold chain, and as well cannot guarantee quality of oxytocin, that became an option. So our work of the first innovation we did was really focused on that, working with the Ministry of Health to change policy. There was work with NAFDAC to get approval in country for the drug. With Federal Ministry of Health, we were able to update what we call the essential medicines list to include the drug. We were able to update the life-saving skills manuals for training health workers across the country. Doctors, nurses, midwives, working very closely with SOGON as well to get those updated, and then working with these 3 states to also update their policy and now train health workers around this area. At the point where we are now working with specific facilities to roll out the new drug and see how it works. At the same time, using implementation research approaches to understand how health workers are interacting with it, the kind of change that is bringing. But I think the last part of what we're also doing, Smiles for Mothers, is taking a systems approach. So it's not one direct solution in a silo. It's thinking more broadly around maternal health commodities. What does it mean to improve access? What does it mean to improve sustainability and guarantee financing? What does it mean to distribute it well? And what does it mean for the health workers at facilities to use them right? So with that in mind, we continue work with the Ministry of Health, drug management agencies, and the health facilities as well to continue to improve quality of care, which is really what MSD stands for. And this platform on Nigeria Health Watch is really helping to push as well. Thank you.
Thank you very much, Uche. You just hit the nail on the head for evidence. Essentially, you've spoken so much largely about the need, and not just working as a project, but also building the capacity of health workers to be able to understand, internalize, and be able to be a lot more productive, because we can't do it alone. We need the health workers to be able to work better and provide quality services with respect to commodities being of good quality as well. Thank you very much. So we'll go over to Dr. Ademola from Farm Access, and we want you to sort of also share your experience in terms of what the challenges were and what the solutions were in, with regards to health workers' capacity being built to provide quality services for maternal health outcome.
All right, thank you very much. I think I will take it from the point of view of a platform or platform-based thinking now. Life Bank has done a lot with logistics. You're doing a lot with drugs, especially the new drug that you mentioned. I think that's actually great. At Farm Access, what we did was that we built what we call Mom Care. Of course, in partnership with MSD for Mothers, who funded it. So Mom Care is actually a data platform. It's innovative, it's integrative, it integrates data from mothers, data from the clinical care pathway, from providers, as well as data from payers into one platform. And that helps with decision making, it helps with tracking the maternal journey, it helps with getting insights into the care pathway, into what causes morbidity in maternal care, into what causes mortality in maternal care. We go very granular. We collect extremely granular data in the care pathway. For example, did the doctor take the blood pressure when the mom came for first ANC? Was an ultrasound scan done? What drugs were given during delivery? One of the things I was thinking about as you were talking was, what's it going to be like to measure the differences in when you're using oxytocin and when you're using the new drug in terms of maternal mortality or in terms of the success of the pregnancy. That's the kind of thing that the mom care platform can do. You know, in the same way, we can plug in something from LifeBank and say, mothers, or rather hospitals who get their blood from LifeBank, how does it change or how does it affect the maternal care journey than those who get it from other blood donor services? You know, so we have an integrated platform that I said tracks the whole maternal care journey. We can plug in so many things and we analyze and see what the insights are. Where can we improve on? What can we improve on? The platform also has a maternal-facing arm of it, of course, that improves adoption. Because first of all, we want to ensure that they are well educated. So we try and educate the mothers in one way. We try and put in place nudges. You know, one of the other speakers mentioned nudge hubs. What we try and do is that just low commitment behavioral changes, we try and put them in place in the maternal facing side of mom care. So for example, we send SMS reminders for ANC. This has been done in so many places, but one of the other innovative things we're doing in mom care is to add transport vouchers. One of the problems that we see with mothers is how did they get to the hospital in time for ANC? How do they get to the hospital in time for delivery? So just giving them transport vouchers and talking to transport associations, Keke Marwa, and other Uber, for example. So that's one of the things we are plugging into that in the maternal facing side. We also have in the provider facing side of mom care, we allow them to see exactly what their care does, the outcomes of their care. You know, so if a provider has this particular habit of doing just one ultrasound, right, we can show them directly through the data that this one ultrasound is causing this in terms of your outcomes, while other hospitals who are doing 2 or 3 ultrasounds have these particular outcomes. Same thing with number of ANC. It's things that we can track. Same things with postpartum education. There's also things that we can track. Using the drugs, also the drugs that you give, oxytocin. In fact, one of the things we have on mom care is actually the use of oxytocin during delivery and after delivery. We actually track that through all our hospitals. So it would be good, like I said, to add this new drug and see how it works, you know, in such things. I think that's a run of the gamut, or that's the gamut of what we do. The key objective, if I can say that, of course, is to strengthen maternal care. That's very important, right? But at Pharmacist, we also have a general care platform called Safe Care, and we're adding that to mom care. So we don't just go in and drop mom care there, right? We come with Safe Care and we strengthen your entire clinical care quality, right? And we build mom care on that. That's actually very, very important, just not dropping that there. And finally, we are looking for more sustainable measures. So we are building this on what I'll call a UHC platform, basically health insurance, right? How can we move from donor funding, thank you MSD, to more sustainable insurance or more sustainable financing platforms like health insurance? So we are building mom care on that. So those are the 3 key objectives, I would say: clinical care, general care quality, and sustainable funding.
Thank you very much. Thank you so much, Dr. Ademola. And it's so interesting to see the innovations across board from the 3 different projects. The fact that there was a need, and there was a need that was identified by an individual that was scaled up using innovations such as drones. And to see that there was that involvement from when the project started to how it's going now and how it's been scaled up to other areas. And you could see with the Smiles for Mothers team that clearly there was a need to actually have a human angle to provision of care, which oftentimes that we ourselves that go to receive care forget about. And the fact that they've been able to bring that to life is amazing. And it's simply beautiful to see how you are already continuing your collaboration right here by talking about the mom care and how you can integrate the heat-stable uterotonic into that platform. That's amazing. So I have just 2 last questions for the team, and that will essentially be, with all that we have talked about here, what would be one key evidence that you would say is what we should continue to use to push for and recommend for a sustainable change in terms of from the government? What key evidence can you speak to with all the work that you do say, oh, this is what we have been pushing for. And if at some point this project ends, this is the acts that we have, and this is the evidence that we are presenting to the state government to say, oh, we want you to look into this evidence as a reason for you to continue to sustain this innovation or to scale it up.
Let me go first with that. So in terms of evidence, in terms of based on our experience in trying to implement MomCare, I'll say 2 key obstacles, and that would inform the kind of recommendations you give to government. The first thing is, because MomCare collects data from providers, we find that there is no structured way of collecting health data, right? You may call it clinical coding, you may call it health data management, but we find that what one hospital does is totally different from what another health facility does. So it's been a problem that we had to overcome, sometimes by taking a step back and now trying to institute a more standardized method of health data across health facilities. Then, of course, recommendation, please give us a standardized way in Nigeria for doing all this. I know NHIA is working on that right now, but it's something that if it could come out and we had that standardized way of health data communication management across different health facilities, that would be great. The second thing, of course, is financing. Right now, we are donor funded, right? But we're trying to look at how can we build something that looks like a vertical program. I don't think it's really a vertical program. That's maternal care. How can we build it into the more general health financing landscape that we have in Nigeria, right? So integrating it into, right now we're currently working with LASHMA to do that in Lagos State, right? But how can we integrate this into NHIA and all their funding programs, into private health insurance and maintenance organizations we have in Nigeria, right? So that discussion, I think, is necessary, right? We're working with LASHMA, but it's still something that we want to do with private health organizations, something that we want to do at the national level with NHIA.
Thank you very much. So, Dr. Uche. Oh, sorry.
Okay, I can go. Evidence. Thanks. I think that's very important. I think, for me, one of the points, one of the reasons why we need evidence to drive action is to scale what works. I think many a time we execute an intervention, it ends at where MSD funding or Gates Foundation funding or whoever funding stopped. 30 facilities, pilot, that's it. If it works, why is evidence not helping us get to scale? So for me, I think the biggest part of how we're thinking about evidence is to guarantee scale. So from the outset, is really saying, what do stakeholders need to be convinced that this is something they need to invest in and follow through to scale? We started in 3 states, so the journey doesn't stop there. If it works, it should go to 37, because there are women that die across all states. So for us, that meant we needed to use evidence to demonstrate that beyond the WHO trials and case studies from other places, it works in Nigeria. If you give it to our health workers in our setting, they are comfortable using it, it makes the change and reduces the mortality in their facilities. That's one. So from the outset, we incorporated an implementation research angle into what we do. And the evidence from that will show anybody that cares to hear that it works. People have used it in Nigeria and all of that. I think the second part of any intervention is cost. And I think you mentioned that very well, Doctor, which is, yes, it works, but can we afford it? Is it a good way? Does it give us value for money, right? So I think with that, every intervention also needs to think about cost effectiveness. How do you compare the value you're getting from it for the cost you're paying across other interventions that you have? Whether it's, so this is his table, but we have oxytocin, you need to use a fridge. Who says if it's cheaper, that much cheaper is not more cost effective? So I think the angle of cost is one part, and I think for our program, we're also using a cost effectiveness model to demonstrate and even test and assure ourselves that this is a good way for government of Nigeria to spend money. And I think from that as well is where stakeholder involvement becomes very critical, because from the outset, we had the Federal Ministry of Health leading, understanding that demonstrating it in Lagos, Kano, and Niger doesn't mean 37 states. So the Federal Ministry of Health is the one that has that platform to take what works across board. So they are closely engaged and will be the one helping disseminate, when the time comes. Thank you.
Brilliant. Thank you very much.
No, I got it. So the team has highlighted most of the points that we need to say, but I'll just say that evidence is in the data. If you look at the data from when we start these projects and the data afterwards, the number of lives that have been saved, the number of cases, postpartum hemorrhage, cases that have been averted, the number of women that have been saved, women lives that have been saved, the number of child lives that have been saved, then it's something that we need to advocate for. I would say that the first main roadblock that we see with the stakeholders, with the governmental stakeholders, is that there's no open source information. So while we're trying to collect data to build drive technology that can help deliver the quality of healthcare, i.e. we're working on an app that can predict the usability of blood in hospitals, but we have very poor access to data. So if there's an open source information, it would help. Also, if there is active collaborations between the government and private companies, and to advocate for, the projects that we've done and, the things that we stand for. For example, blood donation, just to enlighten people and let them know that, listen, we need to maintain the blood pool, we need to save lives, we need to give the quality of care and improve the quality of care. Financing, the team has already spoken about, so yes, I think we've covered it.
Thank you very much. So insightful, and it was a beautiful discussion, I would say. And it goes to say that there's so much to be done in terms of public-private partnership, because that's the only time all of these interventions will be sustained. There is evidence that the different innovations are effective, and there's no reason why it cannot be sustained. There's no reason why there can't be strengthened collaboration for government to support the continuation of projects beyond being led or funded by partners. So that takes us to the end of our session. But before you go down, we want to take a picture with Vivian being a part of it so that the next session can come in. Thank you.
Thank you very much. Thank you so much, Dr. Bolanle, Dr. Uchenna, and Dr. Serrano for that insightful discussion. And thank you, Ife, for leading that conversation, very important. And it's good for us to, hear the insights from the mouth of the horses on what it takes to actually equip and empower health providers, health facilities, and healthcare workers. So just FYI, the report that Dr. Uchenna Ibukwe referred to during his conversation is actually in your folder. It's the nationwide survey of healthcare providers' clinical experiences with the use and storage of oxytocin in Nigeria. and it was written by Dr. Chioma Ejekam, Florence Yagara, Dr. Chimeze Anyakora, and Jude Nwokike. It's right there in your folder, and we can read and learn from that. So without further ado, our able moderator is waiting. So the second panel session. Okay, so we are going to give a chance for questions and answers after all panel sessions. So there's a slight change in the programming. The Q&A will come after all the panel sessions. So please get your questions ready. We'll go around to collect all of them, and our panelists can answer. So for the session 2, we are going to be speaking on expanding access to better quality maternal care. So we are going to have our partners, our collaborators who have been working through their various initiatives and organizations to expand quality care to those who have been underserved or unreached or underreached. So our first panelist is Dr. Meru Mandara, the founder and board chair, Girl Child Concerns. Thank you, ma'am. And then we have Dr. Dayabu Yusuf. Apologies for not putting your title in the program. We have Dr. Dayabu Yusuf. He is the Regional Program Manager, Northwest for the Integrity Project at Society for Family Health. We are happy to have you, sir. All the way from Kaduna. Thank you, sir. And Dr. Mandara, all the way from Borno. Thank you very much. And then we have, last but not the least, Madam Paulina Akanet from Pathfinder International. She's the State Program Manager for the Saving Mothers Giving Life Project 2.0. Thank you, ma. Ify?
Thank you very much, Bumi, and thank you very much, Matt. Thank you very much that you're welcome, and I hope I do not break down in this session. So from our discussion, our previous session, we established that our questions will revolve around the why. What was the push? What was the drive behind the innovation? How did you start? How was your input as an organization and as the project implementers? Additionally, we want to know your evidence. What's the evidence that you want to present to us to say, oh, there is a need for the government to do A, B, C, D in this sector? So please relax. And we can start with you, Dr. Mandara. So hearing Zara's story, I had to get up so that I don't break down. We could see clearly that there is a need in Borno State, even without being told, but we want to hear from you, your experience, your challenges, and your innovations under the MSD for Mothers project.
Thank you very much, and thank you for having us to share our experiences in Borno State. As you all are aware, Borno was devastated by the insurgency of Boko Haram, and for years, schools were closed, hospitals were destroyed, and almost everybody for a long time was gathered in Maiduguri, MMC, and Jere local government. Of the 27 local governments, most people were only in 2 local governments until the last 5 years when government redeemed some of those local governments. And as I speak to you now, we have people in all the 27 local governments in Borno State. So when that happened, healthcare workers, teachers in particular, were killed, healthcare workers ran away, and so therefore there was nobody. Everybody, those that were not from Borno left their states, those that were from Borno also left for other places. But the poor people could not move. They had no means of going anywhere. They gathered in IDP camps. They had no money to go anywhere, and even if they went anywhere, they were going to live under the bridge. So in that scenario, we were faced with a lot of challenges, particularly in health and education. And in particular, as people remained gradually with our military being very brave and opening up some local governments. So there were people in local government headquarters, but there were no healthcare workers. There were women, there were children, there were men. So what we decided to do, and I was very opportune to have been one of those that led the review of the National Village Health Worker Program curriculum during the MDG program. So I knew the content and I knew the power of the village health worker. And a lot of our health problems, especially in maternal, newborn, and child health, in my experience as an obstetrician, can be prevented. We don't have to have women die. It can be prevented. So therefore, what we did was we went to those local government with support from MSD. We went to 3 pilot local governments and looked for young women like Zara. Now, Zara has added about 4 years since we picked her up. So she's a much older lady now. We got young women that were resident in those villages. The only criteria is being able to have primary 6 literacy and numeracy. There was a local government where we could only get 3, and so therefore we had to get women that are intelligent enough to tally. Just 1, 1, 1, 1. After 4 you cross, that's 5. To tally their figures. So we took them, and because we wanted to have something that's sustainable, we picked them from their villages, went through rigorous selection under trees with the help of the traditional rulers and the support of their families. We then took them all to Maiduguri, to School of Health Sciences and Technology. And we kept them there and trained them for 3 weeks as village health workers. We gave them rudimentary training on understanding pregnancy, danger signs of pregnancy. They can tell you when you have edema and you have blurring of vision. They know you are about to have some contractions. They will tell you they can detect pallor. They know all the danger signs of pregnancy. They understand contraception. Even though MSD did not ask us to do contraception, we actually defied them. They didn't want us to do contraception. We said, we're in the field, you cannot tell us what to do. So we did contraception because the need was high. And we never reported because it was they would have a conflict of interest. But we needed it, so we can't run away from it. The women wanted it. So we, with the support of MSD, we trained these women on maternal health, child health, and nutrition. And then we trained 240 village health workers across 3 local governments and 60 CHUs to give them supportive supervision. The CHUs went with them every week to see what they were doing, and they were improving their skills. When we did that, in the middle of nowhere, we got a call from WHO to tell us that they noticed increase in immunization in Bama local government. And they were trying to find out what was happening, and they were told that there were some village health workers that are working. So we were encouraged by that comment. And after that, we shared, because we were working with the government, we shared with the government what we're doing. And the government said, this is the way to go. MSD supported us to train 240 village health workers. The government supported and encouraged us to train through the MCRP program additional 425 village health workers with 210 nurses and midwives as supportive supervisors. When recently in the last 1 year, when the government was closing IDP camps and returning people to their village, for every returning village, we took a number of their women and we trained them as village health workers. And we did a total of 465 of those. So now, although we were supported to do a total of 240 and 60 supervisors, which is 300, we have now a total of 167 village health workers and 270 CHUs and nurses supervisors. What is crucial now is, if you look at the data, look at the national data for maternal and child health. With all the devastation we have in Borno, we're not the worst. The only place that we're not doing very well is contraception. Otherwise, we're better than many states in this country that have peace. And our village health workers are now in all the 27 local governments in Borno State. and the state government has written us a letter to say if MSD could support them to do more, they will now take them up. So now they're working with the National Primary Healthcare Development Agency and the State Primary Healthcare Development Agency to see how those village health workers, they were working for free. She still works for free. How now they can take them up under the CHIPS program so that they can convert them into the CHIPS program. So this is what motivated us. The need was so heavy. And there's just nobody. There's just nobody. So we had to find solutions. And at the end of it, at the end of this experiment, we have about 265,879 women that were able to access maternal, newborn, and child health programs in where there are no nurses and doctors and any formal healthcare worker. Thank you.
Thank you so much, Dr. Manjara. You could see the passion, you know, from her speech. And Dr. Manjara has been able to address all 4 questions. So she has set the pace for us to follow. So we want to identify the gap, the challenge. What's the evidence that we have to show that, the need for expanding access to better quality maternal care? And what's the recommendation for state governments to, you know, take on following the success and the evidence that has been provided for change? Over, sir.
Thank you very much. I think my sister has already laid the foundation and the context of service delivery in Nigeria. If you look at what is happening across the country, you have heavy dependence on public sector for service delivery. And this heavy dependence in public sector creates what one of the speakers in the morning was saying, that the system is being overburdened and private sector is largely untapped. So Integrate E is a project funded by MSD, co-funded by MSD and Bill and Melinda Gates Foundation. And what the project is doing is actually to do a kind of regulator-initiated healthcare reform. What I mean by that is working with the Pharmacist Council of Nigeria to see how the regulation of patent medicine vendors and community pharmacies can be strengthened in such a way that you expand access to healthcare services through these providers that are vested in almost all our communities. Everywhere you go in Nigeria, you have patent medicine vendors all over. I'm sure in the 27 local governments of Borno, they are all there. And also, because of the situation we find ourselves, you find a lot of healthcare workers who either leave service or have graduated from different schools but have no formal employment with government. And most of these healthcare workers find themselves opening patent medicine stores. And for the pharmacists, you have a lot of them, you know, opening community pharmacy outlets. So for most of the communities, you already have healthcare workers with potentials to provide healthcare services, contribute significantly to the reduction of these mortalities, and contribute significantly to improvement of maternal health. However, the policy within the country did not permit this cadre of healthcare workers to provide this kind of services. So what Integrate E is doing with support from MSD for Mothers and Bill and Melinda Gates Foundation is actually to generate evidence that will convince government on the need to review the policy that will now allow patent medicine vendors and community pharmacies to provide services to this population. This is very important in expanding access. For example, if we take most of our states, for example, if you take Kaduna State, you have about 1,000 plus primary healthcare facilities with over 5,000 patent medicine vendors. So if the primary healthcare facilities are operating optimally, and then you also have about 5,000 patent medicine stores that are also providing similar services, and then you establish linkage for referral, you know, to ensure continuum of care within the system, you'd have widely expanded access to the women in the community, and especially the last 2 wealth quintile in our community, and these are people who patronize patent medicine vendors. So that's what Integrate E is doing, working with Pharmacist Council of Nigeria to ensure that the evidence is generated that will convince government to review the policies, you know, that guard the patent medicine practice and community pharmacy practice to ensure that they are allowed by law to provide these services. a lot of work has been done by the partners involved in this consortium. And one of the work is what Pharmacist Olalere just mentioned, the tiered accreditation system that has looked at the, initially PPMBs are seen as one class of healthcare providers, but recent studies have shown that there are people with different health qualification that open patent medicine stores. So the work that PCN has done is to classify this into 3 tiers. Those with no formal health training are classified as tier 1, and those nurses, the midwives, the community health workers are classified as tier 2, and then you have the pharmacy technician as tier 3. So the work we do with them is now to pilot this tiered accreditation. We started with family planning services. We train these different tiers of family planning service provision based on their training. So tier 1 have limit to what they do. Tier 2 takes higher grade services based on their training from the various health institutions that they graduated from, as well as tier 3. And evidence has shown clearly from most of the studies that we have done that from client exit study, from the integrated supportive supervisions that we do jointly with the state and local governments where these services are provided, that the quality of services that are being provided by these health-trained PPMBs is very similar to what is being provided by the providers at the primary healthcare facilities. And through this process, for the 2 states that we piloted the family planning component of the intervention, Lagos and Kaduna State, over a period of 4 years, family planning services have been provided to over 280,000 women. And out of these 280,000, about 108,000 are actually new users of family planning who never had access to family planning services. So based on this evidence, we already have agreed with Pharmacist Council of Nigeria, and now with funding from BMGF, to scale up to 11 additional states, now going beyond Kaduna and Lagos. We are now in Kano, we are in Gombe, we are coming to Borno. Sokoto, Enugu, and the rest of the states that we have selected. But also beyond that, we also have expanded the scope of service provision. We look at some integrated community case management for malaria, for pneumonia, for diarrhea, and also very importantly, the screening for tuberculosis in some of these states. So what we are trying to do is to see how we can generate sufficient evidence that will inform government of Nigeria decision to allow patent medicine vendors, based on this tiered classification, to be providing primary healthcare services, across the community. But also very importantly, link up the patent medicine vendors, the community pharmacists, with healthcare facilities, so that there will be strengthened referral for continuum of care for the women, within the community. And also in terms of reporting, also to ensure that the National Health Management Information System that currently exists in the country is not just a public sector reporting platform, but it also recognizes reporting of health care service delivery from these private providers, so that the whole of the health system, will be taken as one health system, like we keep preaching in Nigeria. So summarily, the work we are doing is just to work with government to ensure that the patent medicine vendors and community pharmacists are recognized as formal healthcare providers within the health lab space. And the whole objective of this is to expand access and ensure that people who live in communities, in hard-to-reach communities, in rural communities that have no access to basic healthcare services are actually able to access these services through these service providers that they have confidence in. And then referral to higher level of care is established right from that community level to ensure that there is continuum of care being provided to women. We believe that if this is taken to scale, it will go a very long way in reducing the mortalities that we have in our country. Thank you.
Absolutely. Thank you very much, Dr. Yusuf. Thank you so much. And one thing that resonates from what you and Dr. Mandara have spoken so far is that there's a focus on what women want. there's a focus on human-centered design, and there's a focus on a holistic approach to ensure that you're not just addressing one segment and the other segment is suffering, but looking at it holistically, which will yield stronger results, as well as promoting public-private partnership. Beautiful. So that takes us to you, Madam Paulina. So you have the floor to tell us about yours in Kaduna State as well.
Thank you so much, and good afternoon, everyone. The project that we're implementing, that is Serving Mothers Giving Life project, it's in its second phase. The first phase happened in Cross Rivers, and it was a 5-year project. The sole aim of the project is to address maternal and newborn health issues. Based on most of the presenters we had in the morning and what my other colleagues have said, we understand the fact that maternal and newborn health indices in Nigeria is a very serious issue. And globally, women and children are among the marginalized, so they don't have voices, and so they need a lot of support. Dr. Tijani said, we already know the problems. It's really what to do as the solutions to those problems. And so SMGL 2.0, that's what Serving Mothers Giving Life is, wanted to look at how can we improve maternal and newborn health, especially now for the second phase in Kaduna State with funding from MSD for Mothers, how we can help improve, one, access of these services to the women who need it, and secondly, improve the quality of care, and then thirdly, see how we can work to improve collaboration between the state government and private health facilities. In Kaduna State, Kaduna has about 334 private facilities, and the project understood this singular fact that there are a lot of activities going on within the public sector, and the private sector is not carried along. And so we lose a lot of women working just within the public sector and forgetting the private sector. So the project is working exclusively with the private sector to see how we improve their services to our women. And it's on that note that we were able to, work with the government, have them understand the role of the private sector, have them understand that in supportive supervision that they plan out, even for licensing, the private sector must be carried along so that they get a complete buy-in of those activities that they want, and they can receive data from these private sectors too. And so part of what we did along with the government was to identify the private sectors we'll be working with. That was with the support of the government, because we came in, we didn't know which private sectors were there. Private facilities, were in existence, but with them we were able to carry out all of those activities, and in the process also help update the database for the government on existing private sectors. Kaduna State is saddled with a lot of insecurities, and so some of the private facility owners have relocated or have closed up. And so the advantage of what we did was to really go out and see those that were still in existence and update what the government has concerning that. Then we also looked at how do we improve maternal and newborn health. The project now looked at it at the process of the 3 delays, so that we're able to be we can know what we are doing, and we are very objective in what we are doing. And so for the first year, we went into the 3rd delay, and that is delay in accessing services within the facility itself. The project was able to work with these 25 private facilities that were selected. We were able to build the capacity of the health providers within these facilities on the basic care, that is EMONG, that is the emergency obstetric care, both for doctors and for nurses and midwives and the CHUs. We were also able to, train them on essential newborn care, postpartum family planning, how to reporting, that is on the M&E component on data and reporting and all of that. Those were trainings we carried on for them. We carried out every training that was necessary to ensure that when our women get to these facilities, they get the best of care from them. Having done that with them, we are supporting them continually with supportive supervisions to ensure that they internalize and become proficient with the skills that they've learned. Then we moved on from there. Having built their skills, we provided some basic things like the anti-shock garment. We provided the penguin suctions for them because those were things that we found out they did not have to be able to take care of women when they get there. Then we had collaborations too with other partners, with Farm Access. Thank God when the doctor from Farm Access was talking, he had raised the Safe Care platform. We were able to, identify and train quality improvement facilitators, and we set up quality improvement teams within each of these facilities, and their responsibility is to ensure that the facility maintains quality. Farm Access also supported in the process of, training these people on how to use the Safe Care platform itself. After that, what we now did was to assess these facilities using the Safe Care methodology tool that ensures that we look at all of the service delivery components within the facility, to as little as cleaning or washing the bed sheets, or to as little as how they take care of their wastes. These were things that are part of the quality issues. And so assessments were made for these facilities. A report was generated for each facility. It's not a general list for facility specific things. They are given a report to tell them what they are doing and what they are doing right. Then a quality improvement plan is also submitted to these facilities. The quality improvement plan helps the quality team to follow the plan to improve on those gaps that were identified during the assessments. So having done that, the quality improvement plan meets on a monthly basis. They look at the quality improvement plan. They are able to, continue to implement and upgrade. And then once they do, they upload it to the platform. And surprisingly, we have a lot of interest from our facilities. Some are even ready for reassessments now. That is to show the interest that we have from them. Then we also partnered with NIVI. NIVI is a partner that we are partnering with on digital health. So what we've done is we sat with our stakeholders to look at messages using the 8 recommended visits for antenatal care by WHO, also looking at information a woman will need during the postnatal period, family planning information and all of that. And so we were able to work on those messages, have it on a platform that is called the Ask Nivi platform. It's a WhatsApp platform. And so women who get to the facility are given the number to, register on board, and they are able to receive messages. The messages are tailored to their ages of pregnancy, that is the gestational age of that pregnancy, what she needs to be receiving based on the recommendations, whether prophylactic treatments, or the routine medicines that she needs to receive. Those are information that are, asked, and the woman needs to respond. Having done that, we also understood that Kaduna being a northern state, we needed to have probably this information translated into Hausa, and that has been done. And so we have information in Hausa and in English on the platform so that women can access these informations. Then we moved on to having created the quality improvement teams. From that quality improvement teams, we've been able to create a sub-group for the MPDSR, that is the Maternal, Perinatal and Death Surveillance Review, that they are now also saddled with the responsibility to review each death that occurs, whether of a mother or of a baby in the facility, and report. We've linked them up also with the state MPDSR committees so that they are able to, report and get support from them. We were able to work with the major private associations, that is the Association of the Private Medical Practitioners and the Association of the Private Nursing Practitioners. We have worked with them. They have been a driving force in how we interact with their members that are working with us. And the major activity we are enjoying is the fact that we want to see how we can reduce out-of-pocket expenses. And so working with these associations to encourage their members to register with the CATMA, that is the state health insurance. The State Contributory Management Agency. I'm sorry, there was a little block there. So all of that happened, and so that we've received a lot of encouragement. Many members that probably did not understand what the insurance scheme was are now willing, and we have at least 3 to 5 that have now registered with the state government outside the people that were already registered. We have enjoyed a lot of support from the government, and I think that's the key, our major achievement, on the fact that the government has been able to agree with us. We have one of the suggestions the associations gave the government is the fact that when there is a licensing or relicensing of private sectors, the associations need to be involved, and government has taken that. I mean, the State Ministry of Health has taken that, and they are constantly in consultation with them, especially when there is a renewal or a licensing to take place. We've also enjoyed the fact that we were lucky the PPP policy development for the state had started, and so for that reason, the private sector was part of that activity. We are also, that's just now talking on the first delay, the third delay. For the second delay, we are working with the TBS and all of that. I'm sorry, I'll just round up now. We are working with the TBS, we are working with the PPMVs, and we are working with our other partners too, so that we can, have synergy on the things that we're doing. I'm sorry that I've taken up most of our time, but for evidence, the major achievements we've had for now is the fact that we have women who are enrolled to receive these messages, and they've given us a feedback that those messages had helped them. We have reduced facility-based maternal mortality at a considerable number, because at now we have up to 60% reduction of maternal facility-based data of maternal mortality. But the major thing is that for perinatal mortality, we have just about 7%, and that explains probably the places where we are working in. The rural facilities, have a lot of problems with anemia and all of the things that affect the welfare of the children. I'm sorry I've taken so much time.
I'm so sorry,
Thank you.
Madam. So beautiful. Thank you so much, Ma. We're really short for time. So I will just essentially put a summary to all our partners have said. It's clear that every intervention has focused on what women really do want. What is our health needs in terms of maternal care? Looking along the continuum of maternal care. And there's a need to, they've observed that there's a need to strengthen public-private partnership. You can see that resonating from the discussion. And also looking at quality, but not just quality in silo, but in terms of the health systems. Building capacity of both the semi-formal and the formal people in the formal sector to build their capacity to provide quality care. And also looking at access to care. You know, so there's a lot of collaboration between public and the private, and also a robust innovations by the partners and the use of data. I've seen them talk about data. We've all heard reference to data, reference to result, because what is not documented, we all know that it's not done. So that said, we could see clearly that sharing of tax and shifting of tax to lower cadres can actually help to improve access to not just maternal care, but to care. And we would like to say thank you for the work you do. Thank you for coming around, and thank you for bringing out your time to share the great work that you do. To end the session, we want to take a quick photograph, and after that, Bumi can have the mic. Thank you very much. Please support us with clap. Yes, thank you. It's not easy to be on this stage. So we want to invite our MD, Vivian, to join in the picture.
Thank you very much. Thank you, Dr. Mandara, Dr. Yusuf, and Mrs. Akanet. Thank you so much for this session. One outstanding takeaway from this session is the importance of collaboration and the importance of knowing exactly what women want. If we want to solve problems for women, we can't just solve problems based on assumptions. There has to be some research, there has to be some discussions. What do these women want? And we use human-centered design to provide, to increase access to these women. So thank you very much for that session, very insightful. And thank you, our able moderator, Ife. So the third session, we've been waiting for this, supporting women's pregnancy journey through better quality of care, particularly through collaboration for better quality of care. And this session would be done justice by these following people from these following organizations. They are the best fit for this, and I believe that it will be a very insightful discussion. So first off, we have Dr. Chibugo Okoli, the Deputy Country Director, JPEGO, and the lead for the Mp4 Project. Thank you, Ma. Thank you for always honoring our invitation. We don't take it for granted. Thank you, Ma. And then next we have Chia Gozi Abiakam, the Associate Manager, Women's Wellness at MDOC. And they are also part of the Mp4 Project that JPEGO is leading on. And then last but not the least, our friend from America, I like to call him that, Daniel Momo, the Customer Success Lead for Navy. Thank you so much. All the way from Lagos. We're happy to have you. Thank you. So, Ife, take it away.
Thank you very much, Bumi. Thank you. It's good to put faces to the names, and it's such a pleasure to have you. So please relax and have a nice discussion. So because of time, we won't delve so much so that people can go back to work today. So this discussion is still the same. We want to understand the gap that you saw that birthed the project. And with that, what were the innovations that you looked into to say, by doing A, by doing B, it will eventually help to address and improve maternal health outcome? And thirdly, with doing that, knowing that with tech, with private sector intervention, there's a little bit of obstacle here and there. How were you able to address these obstacles, and what were the evidence you were able to harness to get you to work with the public sector, and what are your recommendations, moving forward?
Okay, thank you very much, Ife. And I will start. Myself and my colleague, Chiagozie, implement the same RICOM 3 project. But it has two aspects, which is mostly what we do at the facility level, and then also self-care support that we give women. So Chiagozie will focus on the self-care support we give women on the digital platform. But let me go back to how you want us to answer the question. What was the problem, and how did we start, and why this project? Everybody is so aware that postpartum hemorrhage, bleeding, kills women, and our women of reproductive age during pregnancy. But one thing that is not so known is that very, very close to that PPH, that we also have an issue where we have what we call indirect causes that actually also contribute to killing women. And what I mean by indirect causes are things that lead to preeclampsia and eclampsia, things that lead to cardiovascular diseases. So simply, measurement of blood pressure, anemia, obesity, even malaria, HIV, mental health, and so on and so forth. So generally it's called an obstetric transition that we are going through globally and even in Nigeria. And I use this opportunity to actually thank MSD for Mothers for, coming out and putting their money in this area where there is a big gap, because a lot of funders do not look this way. They are focused on PPH, which is important, but actually quite a number of women also die from these indirect causes. So bringing it nearer back home, my colleague Chiagozie presented earlier in the morning, and she showed the figures where before we started the project to do a baseline, we actually did a prevalence study under the RICOM project, where we actually went out and surveyed about 649 women from 4 local government areas. So 2 local government areas in Lagos, where we work, Alimosho and Ikorodu, and then in FCT, 2 area councils, Buhari and Amak. And between those 649 women, apart from surveying them, we actually did a point of care test for them, looking at high blood pressure, diabetes, and anemia and obesity as well, about 400 of them. And the results we got, Chiagozie has already shared in the morning, but I just want to highlight the main thing for us. The main thing was that women, most of them did not even know, were not aware that they actually had the high blood pressure, or that they had diabetes, or that they had anemia, even though their measurements were showing that at the point we did the point of care testing. So we felt, well, this is the evidence for us, in country, in our local place, so something has to be done about it. So we then worked with the state ministries, the FCT, the HHSS department, also work with the Lagos State Ministry of Health to do a co-creation workshop where we also invited women to also contribute to actually using the findings we got to set up an implementation platform. And therefore we call the model a women-centered quality of care model. And in that model, there are 4 components that we try to concentrate on. We try to concentrate on patient education, early detection through screening for these diseases that I've talked about, and then also management of these diseases, high blood pressure, anemia, and co. And then, of course, proper referral and coordination. But there was an important element as well, which was the digital health solution and self-care, and I will leave that to Chiagozie to expand on when it gets to her, because that was an important element as well. We all know that you don't even have much time when you go to antenatal care to list all your problems and get the doctor or nurse hear you out. And so that actually provided another avenue for women to take their problems to and see that that actually was looked into. So for us, I will just concentrate on the health facility, what happened at the health facilities. We actually work across general hospitals, private hospitals, mission hospitals, and primary health care centers. So we got a good cross of the health systems. So we have that evidence that whatever we are doing in the public hospital also works in the private hospital. Sometimes might even be better. You might even have better access there. So we focused on doing quality the way we know quality should be done. For us, quality means doing it for whatever you're implementing, doing it for every woman that steps into that health facility. Every time, all the time, at the right time. So you don't just do it for a set of women and then say you're so busy. You can't do it for this woman that comes in now. And sometimes that happens because of the challenge we have with human resources at the health facilities. So basically, we now encouraged working with the states, we encouraged all those facilities to set up quality improvement teams where, they had leads for them. And we used the WHO framework. The WHO has published a framework way back in 2016 of how you do quality of care around maternal and child health. You can use it for any disease area anyway. So they have what they call leadership is the first one. So leadership way from the state. How do they lead us? The FCT is so interested in this, committed. In fact, I have my colleagues here within the room. And they lead from setting up a committee called Quality of Care Committee. It's not just us being part of that committee, but everybody doing quality of care in the FCT, where we come and discuss, they advise us, and they know exactly what we are doing. Lagos State have a safe motherhood committee who looks into it. Then leadership also at the facility level. When you set up this quality improvement team, you also need leadership to move on in terms of the gaps that they are seeing. The next section is action. What are you then doing? With all these gaps that we have discovered, we encourage them to set what we call improvement aims. You can't work on everything in detail at the same time. So you set up improvement aims. If you know you don't have a blood pressure machine or you're not able to measure everybody that comes in, start there and see what you can do locally. In some places, there might even be just a situation where the women come in, but they don't even have enough chairs to sit down during antenatal care. Go beyond what you can do within the facility. Go to the community. The community, all these churches can help you. We've had so many successful stories from the healthcare workers. So that action, we also encourage them to also come together, learn from each other, advise each other, say what has happened in your facility. Other facilities can emulate that, use data for decision making. And then the next part was that learning. And then the final one is accountability, which is about using data to actually improve what you do at the facility level. So in order to move forward, we started this in 2019, October 2019. I can tell you that at that point, the documentation for those screened for blood pressure, those screened for anemia, people were not even measured for BMI, the body mass index, because they don't even, they weigh them, and then they measure their height sometimes, but they have no idea of how to calculate BMI. So the on-site capacity building that we did as well helped with that. And one sustainable thing in this is that the states actually provided the facilitators that trained these healthcare workers at the facility level. So at that stage, what we were getting in 2019 when we collected the data was about probably 20% or less than 20% of women who attended antenatal care having their blood pressure measured. In some places, they might even measure, but they don't document. And like you said, if you don't document, there's no evidence. So that was the place we concentrated in terms of documentation. And I can say that as of now, 2022, we have over 80% of women coming to those facilities, their blood pressures are measured, their anemia, PCV is done, their diabetes mellitus is checked, status is checked. And, we've also done what we call going back to the patients to actually ask them, did you experience this? And they have corroborated, this same experience of getting all these things measured. So moving forward, I would say that, we have worked so closely with the government that there are aspects of this project that I know that they will easily, be able to sustain and move on, especially things happening at the health facility level. Both states have quality of care committees who looks into all this. So I'm sure that they will be able to sustain those ones. We have also got ourselves involved in there's a national quality of care network in the country led by FMOH. We also have got ourselves involved in that. So this can be carried on through that process as well. Part of what we also did, one of our consortium partners who is not here is the Health Strategy Delivery Foundation. What they actually helped us do was to assess the costs. So what is the cost of what was happening before and what we are now doing? And, surprisingly, for the quality of care model at the health facility, there's a little cost difference. It might just be those costs of capacity building, ensuring that every woman is monitored. So the states can actually take this up, and carry on with it. So we've provided all that evidence, and it's a question of working. We're also trying to work closely with the health insurance schemes at the state level as well to see how they can take on this package. It's actually what they fund, but we're encouraging them to actually fund it so that this health facilities can do proper quality improvement for every woman that comes into the facility. We started off with ANC because ANC is where the women stay longest. But going forward, we've moved to family planning, we've moved to postnatal care as well. So in terms of sustainability, we're very hopeful that the states will be able to take on aspects of the things that were happening, especially at the health facility level. So I'll hand over to my colleague, Chiagozie, to speak about the self-care on the digital health platform. Thanks.
Thank you so much, Ma. Clearly, we could see that the collaboration is coming out strongly from your discussion right here, that it's critical that looking at the continuum of care is not something one person can do alone, and constantly looking into what you are doing and what can be improved and what can be done better. So we'll wait to listen to Chiagozie to tell us a bit more about that.
Thank you, Dr. Chibugo. I think she said it all. But just to add to what she has said, like she rightly mentioned, we conducted a digital prevalence study that showed the gap, in digital literacy, self-efficacy, health literacy, in women of reproductive age. We also noticed that we needed to create more awareness about, self-care approach to managing chronic diseases and preventing it. On the digital side, we noticed we've had some recurring challenges. One, like I've earlier mentioned, is the digital literacy, the lack of digital devices like smartphones, and then the lack of internet data. On the digital literacy side, we have that members have this smartphone. These women use the smartphones, but they don't know how to use it to manage their health. They probably use it for phone calls, WhatsApp, social media, but they do not know how to access it and use it, to properly manage their health. So that's where our nudge hubs come in. So when these women visit the in-person nudge hubs, they get tutored and they get taught how to use their devices to properly manage their health. When it comes to access to devices, most of these women share these devices with their husbands. Our virtual coaches can testify. They call them and the husbands pick up. And the husbands are wondering, why are these coaches calling? So it's now on the coach to now educate the husband on the importance of using, their phone to actually monitor and track their health metrics. So we've had so many cases where our coaches have to, be that like mediate or, help them properly understand. When it comes to the access to internet data, we realized, according to the data we shared, we have that 31% of our WRA do not have smartphones. They use regular phones. And then those that do not have access to internet. So we created an offline platform where they can actually record their, health metrics. Well, we also created a USSD code mechanism where they can actually, send in a code using their regular phones and then have, a coach reach out to them if there were any outlier values or if there was any need. They can also, request to get a call from a coach using those, using the USSD mechanism. So we've talked about the gaps, we've talked about the challenges, our evidence. I think I showed it in my presentation. We record a couple of key indicators just to help us to know when we need to do refinements, where we need to improve on, where we need to be better at. We record, the percentage of improvement in digital literacy, improvement in health literacy, improvement in self-efficacy, knowledge gained by healthcare workers from tele-echo sessions, knowledge gained by our members. We also record process outcomes like exercise, improvements in exercise numbers, or how many people exercise more regularly, or how many minutes of exercise they do weekly. We record outcome measures like blood pressure. We've noticed an improvement or an average improvement in systolic and diastolic blood pressure from an average improvement of 13.6 and 11.8 millimeter mercury in systolic and diastolic blood pressure respectively. And then according to the American Heart Institute, an improvement of 10 millimeter mercury can greatly reduce the cause of death through those risk factors by at least 13%. Okay, so when it comes to our collaborations and partnerships and our role in the RICOM3 project that's funded by MSD for Mothers, we collaborate with a lot of private and public members of the health sector. I just want to even say a big thank you to the state ministry and federal ministry for all the support they have, granted us throughout the course of this project. Our role as a digital company in this project starts from sensitizing the women at facilities about what we do, our platform, how to use it. These women get onboarded onto the platform, and then after that, they get assigned to their health coaches, and after that, they now get added to relevant, online communities, especially for the women that are pregnant or have just delivered. Those communities help them to learn from their peers and also have questions and their questions answered. So after that, we also have our nudge hubs where they can work in and meet in person with coaches and then get taught how to use their cell phone. They get they get their health metrics get checked just when they don't have opportunity to get to the hospital and they need to check their blood pressure and the rest of them. We also have our MDoc Quality Network where we have our tele-education sessions. These tele-education sessions, we use it for capacity building, for healthcare workers, for our members, just to improve their knowledge and then give them health tips. They also have a chance to actually even share personal experiences there, and everybody can learn through those sessions. Yes, that brings us back to our dual-coded platform. So
recommendations, following all the evidence you've talked about now. So essentially, recommendations with public facilities, taking on the digital platform. So what would your recommendations?
Okay, thank you for that. As much as we run a B2C and a B2B business model, B2C meaning business to business, B2C business to consumer, we're currently testing out our pricing tiers. We developed pricing tiers to accommodate women of all demography. And we're testing it out, and I must say it has been very, the results have been very impressive. You know, we're also in conversation with state facilities, you know, on how we can add our platforms to the health insurance scheme, and then they can maybe adopt one of the pricing tiers and then use it to service their members.
Okay,
yes.
Thank you very much, Chagwazi. And it's interesting to see that digital literacy is an area that hasn't really been adopted in the past. And I think with COVID now, everyone is sort of seeing how to integrate digital solutions into their respective spheres of life. And that will take me to Nivi. So Nivi is now going to talk about digital health. You know, your collaboration with all the partners or the few partners you work with under the MSD for Mothers project, essentially speaking to the gaps that were identified and your solution, the evidence for change. And with your evidence for change, what would your recommendations be going forward with ensuring the integration of that initiative into the Nigeria health system?
All right. Thank you so much. Once again, good afternoon, everyone. My name is Daniel Momo. I represent Nivi, a digital health company based in United States of America. And what we do basically is to help with demand generation for our partners, digital demand generation for our partners. We are operationally in 5 countries of the world, even though we are accessible globally. We have 2 business models. If I may just give a brief background introduction about Nivi. We have basically 2 business models where we have the subscription model, basically for NGOs, the NGOs that we currently support, and then we have the marketplace model, which basically is accessible for pharmacy and micro health insurance policymakers. For Pathfinder in Nigeria, I'd like to appreciate Madam Paulina. She has basically encapsulated some of our activities and what we have done so far. And, you know, considering the time constraint, I will just quickly hit it. There are 3 objectives that we identified with, you know, the SMGL 2.0, and that is to, number 1, encourage women to enroll in the ANC program that is available on our platform. By the way, I mixed this. Nivi is accessible and available on WhatsApp and on Facebook Messenger. We decided to use WhatsApp because we noticed that it is better to leverage on existing solution than to try and build a new one. WhatsApp is available in the entire world and has over 5 billion downloads. In Nigeria alone, WhatsApp has over 4 million downloads. And so we have this solution called Ask Nivi on WhatsApp and on Facebook Messenger. And what that basically do is to make sure that, ensure that people get information that relates to their health for free. People are able to make informed and actionable decision with regards to information they get on Ask Nivi on WhatsApp and on Facebook Messenger for free. And so with Pathfinder SMG 2.0, we identified 3 objectives. And the first objective is to ensure that we encourage women to onboard early on the Ask Nivi on WhatsApp, especially in their first trimester. And then the second objective that we identify is to make sure that these women complete the recommended visit that is required, the WHO recommended visit that is required throughout their pregnancy journey, throughout the 37 or 42 weeks of their pregnancy journey. And the third objective that we also identify is to make sure that these women deliver at a supported, high-quality facility. And one of the OKR, the objective and key results that we identify in ensuring that these goals are achieved is, number one, marketing. We need to do awareness. These women need to know that this service existed so that they can take advantage of it. So the first activity that we identified earlier on in May 2021 was to leverage the facilities. So we have the caregivers at the 25 Pathfinder facility onboard these women directly from their facility. Okay, so with the activities for 3 months, we're able to onboard 300 women. Now that gave us a traction and a learning process for us to be able to know exactly how these women interacted with the chatbot, the messages, the curated messages on the chatbot, and also give us an idea of the challenges they have accessing this content on the chatbot. And so by late August, we launched the digital community campaign on Facebook and on Google, and we're able to reach about 1.3 million women, and about 127,000 of them interacted with the ad campaign, and we're able to successfully onboard over 1,000 women between the month of August till December. For the content, we also understood that it is important that the content on the chatbots are relatable to their experience. And so what we're able to do, what we did in that regards was to disseminate 2-3 messages per week for these women. So they get the messages as it relates to their pregnancy journey. And we've had feedback in this regard with women saying that I just got a message on WhatsApp, and I was told that at this time of my pregnancy, the baby could be kicking, or at this time of my pregnancy, I might be feeling dizzy, and if you are experiencing this, quickly make sure that you visit your facility. And they have taken action in that regard. So we make sure that the messages match their experience, the experience of these women on the chatbot. The third key point was to identify barriers to action. We make sure that we identify why these women will not want to, what will be the barrier why they will not want to, take action. Is it the, is it the distance? Is it that, they are not able to visit the facility as at when due? Is it the language of disseminating this content and all that? So that's the third point that we identify. Then the fourth one is evaluating their feedback. Okay, so we run a self-reported feedback where when these women eventually visit the facility, we ask them, have you gone for your checkup? Were you well attended to? What was your response? And with the response that these women provide, we're able to evaluate the system and also, make necessary evaluation and adjustment where required. For challenges, as she has rightly said, the challenges for digital health solution in Nigeria is quite generic. And the first one would be, internet penetration. Even though on paper it is recorded that we have over 51 broadband penetration in Nigeria, these facilities are mostly located in the higher wealth area, where you have them in Lagos and in other western states of the country. For Pathfinder, the SMJ project that we support, we realize that some of these women actually reside in remote areas in the 25 local governments, and that was one of the challenges we had. In fact, in some instances, we had the government turning off the internet because of insecurity issues. So insecurity also added to it, became a factor. We had in New Era, a facility in New Era, and a facility in Zonkwa, where these women were not even able to complete their regular ANC visit because of insecurity issues or because the internet facility was outrightly turned down for a period of 3 months. And that became an issue. And then the third issue that we identified was language barrier. We realized that because of the areas where these women are located, some of them are not that literate to actually comprehend the content in English language. And so what did we do to surmount some of these challenges? Because we realized that some of these challenges are just infrastructural challenges, some are socio-economical challenges. These are things that are somehow beyond us. But for the immediate one that we could identify and we could resolve was language barrier. And because we realized, and because of the feedback that we got, we translated all the ANC content into the Hausa language. So you now have the ANC content available in the Hausa language. That was recently completed about 2 months ago. And right now we are at the verge of running digital marketing and community reach marketing to ensure that we also get feedback and traction in that regard. The recommendation here will be to appeal to the government, to provide an enabling environment, for our solution to thrive. We understand that the government is doing a lot in regards to security, but much is required to be done. Because when you have some of these supported facilities, located where there are IDP camps or where the internet where there is disruption in the internet dissemination, it basically affects our operation, being a 100% internet-driven solution. And then the second one would be literacy. Of course, this is another factor that would appeal to the government to look at in these areas. Some of these women, like she has rightly said, some of these women are not literate, and what they do when they attend their regular ANC visit, and they are encouraged to onboard the Ask Navy chatbot, they get home and they hand over the information to their husbands. So on our ANC report, when we check the analytics, we discovered that we are having men as part of the statistics. We have, of course, maybe 90% women, and then we have some men. And then we realize that, what happened is that when they get home, these women hand over this phone to their husband, and then their husband enroll them, in the chatbot as men. So we appeal that, literacy education should be done in terms of literacy level. With regards to finances, we are also considering, we are in touch with the Lagos State Health Insurance Board, and we've also contacted some time ago the Kaduna Health Insurance Board to ensure that we also provide, health insurance covers for these women, so that when they do attend their recommended ANC visit, they also have a package, a health insurance package that can go along in supporting them. And this is what we have done so far. Thank you so much.
Thank you so much. Thank you very much, Daniel. To summarize this session, I would like to emphasize on a few points that they've sort of discussed. That it's critical that we understand that technology has come to stay. And this is not going to be the last pandemic that we're going to experience. So we need to take learnings from this to ensure that digital health comes to stay in whatever form. A strategy to also ensure that at any point in time when there is insecurity and the internet has to be turned off, there has to be an alternative. Because babies don't know when the internet is turned off or when it's on. They decide to come when they want to come. So it's great to see the work that JPIGO through RICOM 3 and MDOC as well as HSDF are doing with
letting people know, increasing people's awareness, women and husbands, about knowing how to care for yourself, because women largely know how to provide care for people, unpaid care, but taking care of themselves as women is always secondary. But through the MDoc application, they've been able to let women know that you need to be able to care for yourself first before you be able to care for persons, mentally, physically, emotionally, and otherwise. Additionally, they've also emphasized on the importance of data, using data to inform their next level of care, using data to inform their strategies, and again, through collaboration with partners and health workers as well, because they can't do it alone. They need the health workers, their capacity to be built. They need them to internalize these solutions to be able to carry it on and continue even after the project lifespan. And lastly, we all know that now universal health coverage is mandatory in Nigeria. So they are on the right path with the use of digital technology so that the health facilities do not suffer. You need to be able to provide a level of care through digital health. Thank you so much for all you do, and we look forward to seeing more results, and we look forward to greater success being tracked and documented as well. So we'll have a quick picture, and the MC will take it up from there. Thank you very much. Please, a round of applause for us. Thank you, Bumi. And that will be the end of our session for the panel discussions.
Thank you very much, Ife. Thank you so much, Dr. Okoli, Chiagozie, and Daniel. Very insightful session, and one that highlights the importance of, once again, understanding the woman's journey and channeling her solutions to that. So very quickly, we would like to take the questions and answers. And I hope we still have some of the panelists, the speakers around. We'll be taking some questions from the audience. I know a number of people have approached me about that. So we'll just be taking a few questions, and if I would have Betty help me with that, please. Thank you. Thank you. Thank you. So who has a question, please? Okay, so we have someone here. Okay. Here at this table. Thank you.
Thank you.
Thank you, sir. Please, can you introduce yourself first?
My name is Dr. Anthony Ewodage. I'm from Lagos, and I came with my president, Association of National Private Medical Practitioners. I will say I'm highly humbled, and I'm highly impressed with what I've learned here today. I have one or two things to say before I will just ask a simple question. Number one, the trainings that have been given to most of these health providers, I want to say something on it. Please, most especially the ones in the rural areas. Most of these people, I just pray as you train them, you make sure you take them into consideration and place them into government of that state or the local government of that region, because this might jeopardize what you are doing. Most of them might decide to turn it into their own private practice. And when what we are talking about here is maternal quality care. We think of, when we talk of quality care, we are thinking of almost all private sectors, like what my boss said here. Private sectors provide 70% of health care in this country. There's no doubt about that. And that is commonly seen in the southern part of Nigeria. In the northern part, you have a lot of distances you will go before you find facilities. When we talk about primary health care, that is the basic. That's the basic. Primary health care. That's where you get what you want to get. Everything we are talking about here can be completed within the primary health care level, which includes almost 80% of almost all private clinics in the country. Secondary health care, general hospitals, tertiary teaching hospitals, they don't even need to be included in what we are talking here, if we can get this thing right. So my questions now are, what are we talking about when we talk of trainings and equipments? What are we talking about when we talk about training and equipment? Because I had people talking, taking your BPs, taking this, taking that. They are very essential. Because when we talk of death, I'm so impressed. When we talk about maternal death or perinatal death, it's just a small thing, thin line, just simple line, and that is the end of it. I think we have gained a lot from this. Thank you.
A response to that. Sorry? Yeah, okay.
So thank you very much. When you talk about the training we do for Integrate E program, what we do is actually training the healthcare providers from the PPMBs based on their tier, using the accreditation system, and the community pharmacists. We actually have two models of training. The first model for patent medicine vendors, we train them through the School of Health Technology. Now, why do we do this? Or why do we choose this approach? We decided to do this because we want to make it a sustainable intervention. If the schools of health technology are trained, especially those schools that are offering pharmacy technician courses that are accredited by the Pharmacist Council of Nigeria, it means you have institutionalized the training, and even after the project, the schools can still continue to provide this training. And the training is simple. It covers those basic primary healthcare services that they are expected to provide for family planning, for treatment of malaria, treatment of pneumonia, and very importantly, also identifying points where there are complications that they need to make referrals. So that's the model of the training. There are manuals that are developed that comprehensively address most of these issues, and with the limit for each of the services where they need to stop and where they need to refer to the higher level of care. And the whole objective is to ensure that these services are available within the community. So for us, we train them, yes, your fear is genuine, but for us, we train them to actually provide the services within their community. So they are expected to really take the training on and then provide the services within their healthcare service domain. And like I said earlier, the whole idea is if the tiered accreditation system finally get endorsement from the National Council on Health, it means nobody in Nigeria will just wake up in the morning and go and open a patent medicine store without passing through that training. And that's why it's called mandatory entry point training. So it's all about strengthening the quality of services these cadre of providers are providing, but at the same time also building their capacity to be able to meet up with those quality services that we are expecting them to provide. Thank you.
Thank you, Dr. Yusuf. I was wondering if Dr. Okoli had, Okay.
I just
Dr.
quickly want to
Bolaji.
add to what my colleague said. My name is Adeshala, the Regional Program Manager for South Integrative Project. In addition to what my colleague has said, we don't just train them to go and provide services. Before we even start the training, there's something you get from the State Ministry of Health. We get from the Federal Ministry of Health through the Pharmacist Council of Nigeria. That's the waiver. Then the state also give approval to say go and train this set of people. And before they can start providing these services in their facilities, they go through what we call competency training under the supervision of public sector providers. So they go to health centers. Before you can do injectable or implants, you have to do about 12 to 15 insertion as a trained nurse or CHU that is now retired as working as a PPMV. So you have to do that competency certification that will be signed by the MOH at the local government level. The state signs up on their logbook before they start providing the services. And there's lots of supervision and regulation that is also going into this. We have integrated supportive supervision that involves the State Ministry of Health, the Primary Health Care Board, Pharmacist Council of Nigeria. So quarterly, they go out to do inspection while the project team also go on routine supportive supervision to ensure that the quality of service is not compromised.
Thank you, Dr. Bolaji. Thanks for that insight. Dr. Okoli, Betty, if you just, Dr. Okoli will just give 2 minutes, and then we'll move to the next question.
Thank you, Bumi. Just 2 minutes. My colleague has actually said all the things on my mind, but I just also want to ensure our colleague that everything we do is with the state. So for the RICOM 3 project, the curriculum we use is actually the one adapted from the WHO, the package of essential interventions for non-communicable diseases, adapted by the government as well. The facilitators are from the states. They are even part of the health facilities. They are QI leads from the health facilities. So everything, the state is very aware. And my first colleague that spoke, I really like what you said. The key thing is to train them well, and so they know what they are doing. So whoever they provide that service, even if they go to their own private wherever and do, exactly, that's what you want, that they are trained, because it's a human being that they are also providing that service to. Thank you.
Thank you very much, Dr. Okoli. Thank you. I hope that answers your question, sir. Betty, the next question. Thank you very much.
Thank you very much. I am Dr. Otamere G. Aibogun. I'm the National Treasurer, Association of Nigerian Private Medical Practitioners. I have a facility that I equally manage in rural area. I have community pharmacists, I have patent medicine dealers, I have CHUs and TBAs. The problem we are having is delay referrals to our private facilities. I'm not against people training people to give health services, especially in the north, when we have a lot of shortages of practitioners. But what I'm saying is that we should respect red lines. Even in teaching hospitals, we should have red lines. In private hospitals, we should have red lines. Then even the patent medicine stores, they should have red lines. We are talking of quality maternity care. The deaths we are receiving, they are delayed referrals to facilities that can assist them. Even in the best practice, the best facility, if the patient is not brought there in time, there can still be mortality. So while we are doing trainings here and there, let us instill in them that you should know your limits. If you know your limits, you are not going to have much problem. Then concerning blood transfusion, yes, I agree with somebody who made mention of blood transfusion having problems with refrigeration. But what we do in our practices, because of the difficulty in preservation, we take blood from relatives, donate. We don't even keep in fridges after due screening. So I think we have been able to solve those problems through there. But I want to insist on that red line. Thank you very much.
Thank you for your question. Any other question, please?
Thank you. My name is Dr. Ini Ekong. I'm the focal person for Maternal, Newborn and Child Health Quality of Care Initiative in the FCT Health and Human Services Secretariat. And I'm really happy to be here today in the midst of very great people doing great things. You know, I was just talking with my colleague here that amongst the panelists, there seem to be more women, you know, than men, you know. So women are actually doing great things for maternal and child health. Maybe there is need for male health so that women can also help us. That's just by the side. So I just want to make a few comments. You know, first, Dr. Bolanle from Life Bank. I would like to know the relationship between what you're doing and the National Blood Transfusion Service, and how can integrating with that help in sustainability beyond your project life cycle. That's one. Then for Dr. Uchenna Ibukwe, thank you for the good work you're doing, but I wanted to also be clarified, because I'm aware that there's a National Council on Health resolution on the use of misoprostol instead of oxytocin in resource-limited settings. So I don't know how that goes with your carbetocin. Is there that sort of directive? You know, because we in the FCT, what we're doing now is, if you don't have any means of refrigerating your oxytocin, we're telling our frontline health workers to go ahead to use misoprostol in line with the National Council on Health directive. So I would like to see how that matches with the introduction of carbetocin. And then also, yeah, for patent medicine vendors, I think it's a great work you're doing in terms of, you know, access, creating access. But I think for so many years now, we've been talking about access. You know, if you remember the years of the MDGs, we're talking about expanding access. But the question still remains in, after the access, what is next? And that is where the quality comes in. So right now, we are in the quality of care era in the Nigerian health sector maturity. So I think it's important, it's good that we increase access, but perhaps what is more important is to ensure that these vendors are actually delivering qualitative care to whoever is accessible to them. And then lastly, but not the least, is Daniel Momo. I'm also a digital health person, so I think it's very interesting what you're doing. But you know, it's also very important to create linkages between health system challenges and digital health implementation. You know, I think one of your panelists, Chia Gozier, also gave a very, very interesting aspect. You know, when you know, right now, amongst the health system challenges are social determinants of health. Like you talk about insecurity, you know, that will lead to putting off network, talking about access to water and all that, you know, poverty and all that. So I think it's important. Kayode talked about using USSDs, you know, which you can actually access, USSD code, which you can actually access through basic feature phones. So I think in also planning digital health implementation, it's important to recognize how existing health system challenges can influence the deployment of these technologies.
Thank you.
Thank you very much.
Thank you very much, sir. So I would say for your question to Dr. Ibukwe, he had to step out to another meeting. So we're going to take that question to him and would present it to you after he does answer the question. We'll ensure that happens. So Dr. Bolanle, while you were out of the room, he presented the question to you. For Life Bank, your relationship or your level of collaboration with the National Blood Transfusion Service, I think I'm right, and where you are in terms of the life cycle of the program, right? Sorry? Yeah. Yes, exactly. So I don't know if you can answer that. Betty will give you the mic.
Good afternoon again, everyone, and thank you for your question. With the National Blood Transfusion Services, we're about to start. We had started to speak with you guys. Are you part of the team? Okay, so we had started to speak with them, and we were trying to develop a center together where we could actually do the screening and blood housing together, but that was stalled and it has just restarted. Now, your second question, what was your second question? How do we have sustainability? So Live Bank works on, the business model that Live Bank employs is a combination of a sliding scale and what's the word now? We use different pricings for different hospitals, and that's the way we're sustainable. So if a high-end hospital has a need for blood, the charge will be significantly higher than the charge for an underserved hospital. We also have, leverage on we have a blood and oxygen access trust fund where we leverage private capital and treat and serve the underserved communities. So we have people donating to these private funds, and when we have people that cannot afford the critical medical supplies that they need, we use the money from this fund to serve them. So this is how we're sustainable. We also, of course, because of our previous partnerships, we have new partnerships coming up that help us. It will help if we had partnerships with the government too, though. Does this answer your question? Okay.
Thank you. So in 1 minute each, please, Daniel and Dr. Yusuf, if you can give your responses to his comments, please. 1 minute. Thank you.
All right. Thank you, sir. I would say recommendation we're taking. But USSD and SMS were actually considered as a medium of disseminating the ANC content. However, because of the nature of the type of content we deliver, we realize that this medium or this media may not be absolutely suited because we are talking about giving these women, a tailor-made, well-researched information regarding their ANC journey. Is quite different from when you are just, sending nudges or you are just disseminating a broadcast message. And it is also required that they respond as well. So with the content that we currently have and the nature of the kind of feedback we are expecting from these women for proper analytics, it will be, USSD and SMS may not be well suited for such purpose. However, we are indeed considering alternative means of disseminating these messages maybe for other head topic. And I really want to appreciate you for such recommendation. Thank you, sir.
Thank you once again. I just want to respond to some of the questions that he raised concerning the patent medicine vendors. He talked about, we've been talking about access and all that. And I want to say that it's in view of access to healthcare services provision by patent medicine vendors and CPs that the PCN went into this endeavor. So currently it's in the pilot stage, and we had gracious support from Society for Family Health through the Integrate E project. Like I also said, some other partners are also into supporting us. So when we have a lot of support, we will have a good cohort or a good number of patent medicine vendors and community pharmacists being trained. So it could become, with that, it could become a policy nationwide. So at this stage, we are still piloting, so we need a lot of support. PCN is a federal government agency. We know what the situation is. So when we get that support, access will be, more than will be expanded. Then on quality care by PPMVs, in fact, that was what was at the center of the tier accreditation system, because we tagged that repositioning, we tagged that system as repositioning of the patent medicine vendors for quality service delivery. And that's what led the PCN to stratify. So we had the lower cadre, the middle cadre, the upper cadre, so that they can be adequately trained to provide services at their own level. And then somebody also mentioned we have training manuals. And that training manual have gone through quality control. And this this activity has been on for the past 5 years, and we have seen the communities that they serve, because research are also being done as the project is going on. We had a lot of feedback from the community that quality service delivery is the case in their community, in family planning, in primary health care service delivery, like on childhood diseases and some other services. So we had that at the back of our mind in developing what we have on ground for the rural and the hard-to-reach area, and it is working, I would like to tell this meeting. Thank you.
Thank you, ma'am. Thank you very much. Sorry, let Dr. Yusuf comment.
Yeah, thank you very much, Pharmacist Olalere. She has responded to the issue of quality, but I just want to add on the red line. I like the way he put it, red line. And that's the hallmark of the training that you provide to PPMBs and even community pharmacists, is basically looking at what can you do and where is the red line, and this is where you can't cross, refer. The whole essence of this intervention is actually to strengthen quality. The community pharmacists as they are now and the patent medicine vendors are still providing these services. But the major challenge is that they are poorly regulated, and then most of them lack the capacity to understand what they can do and what they cannot do. So that's the whole essence of this that we are doing. And the whole essence of the tiered accreditation is to split them based on your training from the health training institution. What are you trained to provide? Provide those services that you are trained to do. For you that has not been trained, don't go into those services. This is a no-go area for you. So the whole essence is actually to strengthen the quality where we are expanding the access to care. Thank you.
Thank you very much. Thank you. We'll take about 2 more questions. Okay, one from Dr. K and then from, yeah.
Thank you very much, Dr. K. Adeshala. Dr. Bolanle stepped out. I think I heard 1 or 2 people talking about taking blood within facilities, screening them and giving when there is the need. And she was not around to pick that, to respond to. That is one. Number 2, in Lagos State, we have a very strong blood transfusion supervising organ of the government. It's as bad as if there's any little information getting out of a facility, no matter how busy that facility is, that transfusion has been undertaken from a donor to a patient, no matter the level of emergency. That's the area we are still contesting. No matter the level of emergency, it is expected that you should never take blood from a relative and give to, a patient, no matter the dire need of that patient at that point in time. First thing that will be done, that facility will be shut down, to be broadcasted, will be blackmailed, because everybody in the state will know that something has actually happened in your facility. What we do in Lagos, all blood that must be transfused within Lagos State must pass through government screening. So what most of the laboratories do, they take the blood from their donors, do their own screening, and then still pass it to the government for double screening. It is only after it has been screened by the government that it's now returned with the government logo on it. And that is the only time you can transfuse within Lagos. And the law is so bad that you don't even have an option of fine in court. It's a 2-year jail term. No option of fine at all. Yeah. So most doctors are staying away from that. And they've told us that, look, if you must do that, your emergency transfusion, take that patient out of within Lagos State territory. Can go to Ogun State, transfuse there, and bring back to continue treating. It is that strong. So I want Dr. Bolanle to tell us
how they've been able to cope. Because Life Bank, my people in my laboratory, they do call them once in a while to supply us blood as well. So how they've been able to cope with getting blood when it's needed in such emergency situations. Thank you.
Thank you again for that question. As I mentioned earlier during the panel session, we work with only accredited blood banks. We know the strict regulatory body in Lagos State, and we know the negative feedback or the effect of using blood that has not been accredited. I mean, you could put yourself, you're looking at a lawsuit right there. So we only work with the blood vials that have the sticker that say accredited. The government logo, yes, the accredited blood banks only. We're lucky to have a good relationship with LBTS and Luth and a few other private blood banks. So when we do need blood, we've always been able to meet the demands. But we don't work with outside private unaccredited blood banks. It's a strict no-no for us.
Thank you very much.
Does this answer your question? They should, of course, the government policy should come into place. Of course. Because, I mean, there's so many risks. This is a definite risk aversion.
Yeah. Thank you. Thanks, Dr. Bolali. So we'll take, can we take one from Dr.
All protocols duly observed. I just want to add one or two things. With regards to all the interventions we are doing, it's good and we're making a lot of progress. But I would like us to intensify on making the populace to be owning the interventions. Because sometimes there is that gap. They just see it as government or non-governmental interventions. Sometimes there are interventions that if we go to deep into suburban areas or rural areas, they will tell you that, you are NGOs or government, that somebody is excavating our land. So we are not going to take your interventions unless you talk to the government that they should stop. So they in a way, they blackmail you, or they show you that they are not going to accept that intervention unless that other problem has been fixed. So what I'm trying to say, let us intensify on showing them that these interventions are for them and let them own it. Once the populace own it, it becomes very easy. But if you are doing something and he is seeing it as if maybe accepting it is like he's doing a favor, I think there's a lot of gap. There was a time, if you look at the elections of the United States, most of those boys that are counting those votes, they are just volunteers. They just believe, okay, we must take this president out. So they come and sit down for 1, 2, 3 days and do it. So this kind of owning and intervention, I think we should try and intensify it on our populace. Then secondly, the issue of the part-time medical vendors. In Kano too, we have started training about 1,000 of them. So if you look at it over time, number of people that go to hospitals is reducing drastically. One, people are getting poorer, protocols in hospitals, and sometimes attitude of healthcare workers also. Like in my place, there is a part-time medical vendor, one store. I realized over time, within a year, a lot of people are patronizing this boy. He's a Jew, actually. So I made effort to ask our neighbors, but because I realized a lot of them go there, I said, why is it that you don't go to the general hospital? It's just 1 kilometer away. You prefer going to this boy. It's much easier. You won't spend more than 5-10 minutes. If it is injection, he will see you, he will give you injection, blah, 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 blah. So we don't waste much time. But if you go to your hospitals now, the nurse will say, okay, sit down, the doctor is not around. He will come. Or they will tell you something, very demeaning. So what I'm saying, these things are happening. So maybe what Integrity is doing, they are just trying to make sure there are regulations. And let's make sure that there is a limit to what they do. But I understand your concern. If we allow it to be open, we will just wake up and realize that all the private outlets have turned into clinics. Because in Nigeria, regulation is a very difficult task. But I think with intensive supervision and training, I think we can do a lot.
Thank you,
people.
Dr. Tijani. Thank you very much. Thank you. I think if I allow, we can go on and on and on. So if we can have the last comment from Dr. Evodage, I think he requested for that.
I wanted to ask a question to Dr. Bolanle, but I decided to skip it. But let me make a comment. I think I was informed about this just 2 days back. I won't ask you the question again. Because it's a national problem. I was informed about this just 2 days back by my president, and that was Monday evening, and I said I would try. But I think I've gained a lot here because I'm also helping Lagos State government in some other things like this. And I know when I get back, I will put some of this when they call me.
Thank you very
to
much,
the Lagos
sir.
State Primary Health Care Board and let them know that people are really working. I know some of those that are doing this project, some of these organizations are using Lagos. But I told them during our last meeting, just on 2 months ago, 2 weeks or 3 weeks ago, that the minimum service package that you can give to the general populace is a standard. It's a standard. But here we are not even talking of the general populace. We are talking of quality maternal care services. Because what I hate most is maternal death or anything related to perinatal death. Before he left yesterday, he had 2 CS to do. He had 2 CS. You can imagine it's not there now. If there is no early referral, that is it. That is why I said it's just a thin line. Early referral. A lady, sorry to say this, 3 weeks back, a lady came to the facility around 11. And she came, when she wanted to enter, she fainted. And when I looked at her, she was white. I referred her immediately to the general hospital because I knew it has to do with blood. Why I'm talking about the training is they must be well trained so that they can decipher from the right or the wrong. The first thing I tell my nurses, any patient that comes in, look at the eyes. Once there is no blood, there is no blood. No matter what you want to give. That's just the truth. I rest my case here. Thank you. But you are doing very great.
Sir. Thank you very much, sir. Thank you very much. Dr. Yusuf, you've been signaling me. Please, just 1 minute, please. Just 1 minute. Thank you.
Thank you very much, Bumi. It's to our partners who are working on digital technology. But also to give background, Integrity also work with NIBI on creating demand, and we work with An Impact on digital training for community pharmacists. So we are all part of the team working with the digital technology. I kept asking myself this question: if we are using WhatsApp, we are targeting women in hard-to-reach communities, we are trying to reach the unreached. How many of them truly have Android phones that they can be able to access WhatsApp and even get messages? Maybe because I come from a village. I think for me, our digital partners should really think beyond WhatsApp. Let's find other ways that we can reach the women in hard-to-reach communities, the women that we are striving hard to reach. Most of the ones we are reaching through this digital technology, I can assure you that they are privileged. If a woman has an Android phone, she's already a privileged woman. I'm sure the women in this hall will agree. So let's find other ways that we can reach the unreached. Thank you very much.
Thank you, Dr. Yusuf. I'm sure the partners have noted that. Thank you. Thank you once again to all the panelists, to the speakers, our stakeholders from both public and private sector. We really appreciate your contributions. Everything is noted. Everything is well taken. We've taken the insights from the conversations, the highlights, and we've noted it for, for continuous improvements in our advocacy for better quality maternal health care. And just to kind of sum it up before I give the mic to our managing director, we've, following efforts of the Mp4 Mothers partners in Nigeria, we are really happy as co-collaborators of the work they are doing. And this event, this meeting was majorly an opportunity for them to share the outputs of their projects, their interventions, the impact so far, the challenges, because obviously from the comments, from the questions, these interventions are not without challenges. And it is our hope that this meeting provides insights for better collaboration. I'm happy that there's a mix of both public and private sector. There's a mix of both the implementers, the communications experts, and then the stakeholders, public and private sector, like I mentioned. And it's our hope that through this, we get to see the solutions and, kind of deduce actionable steps for probably scaling up or sustainability or funding, because we heard from some of the panelists, these interventions have been done. We know the integrated project is at the pilot stage, although they are now expanding to other states. But there's an opportunity for government to come in, not just in terms of funding, but in terms of technical support from the private sector and just mainly collaboration and partnership for progress. I'll give the mic to Vivian Ihekwazu, the Managing Director of Nigeria Health Watch, to give her closing remarks. I hope I have not missed anything. I really do hope I have not missed anything, because that seems to be on our agenda. But before that, during the panel discussion, someone came in. I would just like to recognize the presence of Mrs. Tayo Olufemi, Assistant Director and Logistics Officer from the Family Planning Program at the Lagos State Ministry of Health. You're welcome, ma. Thank you for coming. Thank you very much, ma. So without further ado, I'll give the mic to Vivian Ihekwazu to give. Thank you. Can we have a better mic, please? Please, a round of applause, please. Thank you, Ify.
Thank you very much, Bumi and Ifemwa, for a very well moderated session. I think somebody would even think you work for WHO, the way you stepped in last minute to give that presentation, so well done. It's been a very busy morning, early afternoon. And first of all, I'd like to, of course, thank our stakeholders who made it here this morning and spent this morning. And it's really wonderful to hear that you found this session very insightful and learned a lot, and we'll take back some of the findings and some of the insights as you work for government. And of course, thank you so much to the Mp4 Mothers collaborators. I think this session has been very good in terms of enabling all of us together to get a better understanding of the projects that we're doing, and also an opportunity to now see where the opportunities to collaborate further and share learnings. I'd like to point out two things. I know Bumi mentioned it briefly, but first of all, in your packs, you will remember the mention of this document. This is actually a research paper that was written by Dr. Ejekam and Professor Anyakora, and it was funded by Mp4 Mothers. And it's important because when we talk about evidence, what evidence informs policy? Evidence based on actual research, data. So this paper she wrote was very insightful, and we supported her in terms of turning it into a more visual document of the paper. But you can easily find it because the code is there. The DOI code is there in case you want to read the actual paper itself. And second of all is the Why Women Dying report, which you will find. And this is the community informed maternal death review that I mentioned. I welcome you all to read this in detail, as again, when we talk about evidence of why women are dying in communities, that project we did kind of provides that insight. And of course, also funded and supported by Mp4 Mothers. So as we go to our various places of work, those traveling back to Lagos, Borno, Kaduna, where we've all come from, first of all, safe travels. But second of all, let's not leave this as the end of our collaboration. Let's use this as an opportunity to grow our networks. We'd be happy to take people's email addresses if you don't have each other's email addresses and support you in further connecting. But we use this as an opportunity really to strengthen those partnerships. I know MSD for Mothers often brings us together, but I think there's a lot we can do ourselves to support each other in the work we do, because ultimately we're all working for the same goal, to improve maternal care in Nigeria. So I think that's it, because I don't want to keep you long. We've gone over the scheduled time. After this session, we will synthesize a lot of what has been discussed, and we will disseminate a kind of a brief report on what was discussed. Wonderful Nigeria Health Watch team are here. If you have any questions or you want to find out any more information about what we do, or any other details about some of the projects that we've been supporting you with. But other than that, I will just say once again, thank you very much. I think it's been a very rich session. The 3 panel sessions, I think, threw up a lot of insights that we can actually learn from. So without further ado, I will say thank you and have a good rest of your day. Bye.
Provided informed commentary and in-depth analysis.
Okay, thank you very much, Vivian. Lunch is ready. Lunch is served. We are at the end of the event, of the meeting. So if you just go out there and pick up the lunch from the buffet, and we're done. So before that, we'll just have a group picture. I did not ask for this. I kept being nudged. We need to take a group picture. So if all the panelists can please come out for the group picture. We would have it over here. And then after that, we'll have with the stakeholders and our partners from public and private sector. Thank you. Sam? Vivian? Group picture. So, Dr. Mandara, Dr. Okoli, Dr. Serrano, Dr. Yusuf, please. Dr. Bolanle, Daniel. I know we love pictures here at Nigeria Health Watch. We love pictures. We love pictures. Sorry? Yeah.